सीरियल स्टार्ट हो गई है क्या?
Good morning, Subhay sir. Am I audible? Sir, kindly unmute yourself.
Am I audible, madam?
Hello, sir.
Yeah, Prerna madam, am I audible?
No, sir, you're not audible.
I have unmuted myself.
No. Are you using a Bluetooth, sir?
Yeah.
But kindly check the audio and speaker. Beside the mic icon in Zoom.
Am I audible now?
No, sir, not yet. So beside the mic icon, there is a small arrow in Zoom meeting itself.
Yeah.
There is a audio option like the mic in the Zoom meeting, sir.
Am I audible now?
There is an audio, right, sir? Mic icon.
Audible now?
Yes, sir. Yes, sir. Now you're audible.
Yeah.
So, sir, would you like to test the screen sharing before we start?
Yeah.
Sure. Thank you. Yes, sir. Your screen is visible. Just need to make it full screen, sir.
Yeah. Is it okay now?
Perfect, sir.
Okay.
Sir, would you like to change the slides once? Just to check whether slides are moving properly or not.
No, it's okay.
Okay. So that just let me confirm you. That is, I will be starting with a brief introduction about Claudette platform, and then I will be handing over to you, right, sir?
First, we will, start with what is the CME you are conducting, and then I will mention that Planet is our, handling partner, and after that you can take over and then give it back to me. Yeah.
Thank you.
मेरे को भी सर बिना उसके हाँ बताएंगे जी मीटिंग अब स्टार्ट होगी
And also requesting all the delegates who are joined with us, please keep your video and audio turned off.
Mr. Madam, can we start?
Recording in
Yes, sir.
progress.
Please proceed.
Good morning, everyone. I am Dr. Zubair Khazi from Elite CME Academy and Indian Institute of Medical Science and Research. I welcome you all for our sixth two credit point CME on comprehensive overview of post-COVID complications, a multi-systemic analysis of long-term. Elite CME Academy is conducting uh, MMC accredited CMEs from last 1 year, and before that we have experience of around conducting more than 50 CMEs. We have our director with us, Dr. Shafi sir. I welcome him and I gave him over the speaker and mic to give a brief introduction about Elite CME Academy.
A very good morning to all of you. I welcome you all to Elite CME Academy. Today is our sixth MMC Accredited CME. I welcome all delegates who have registered for this webinar. All of you know that 2019 we got a very huge pandemic of COVID-19, and it's almost 5 years for that. So Elite CME Academy thought that why we should not brush our knowledge regarding the post-COVID sequelae and its complications. So our dynamic faculties, they have taken the responsibility to put a light on post-COVID complications and its long-term sequelae. So once again, I welcome you all, and I am very thankful to our parent institute, JIIU's Indian Institute of Medical Science and Research, Badlapur, Jalna, our founder chairman, Maulana Ghulam Mohammad Bastani Sahab, may Allah grant him Shifa, our beloved chairman, Maulana Huzaifa Bastani Sahab, for his support, Dr. Ilyas Mehmet Sahab, Chief Executive Officer, JIIU Sahab, our beloved and dean, Zarema Siddiqui, who is the driving force of conduct such programs. Our BCMA Academy team, myself, Dr. Mohammed Shafi, and Dr. Jabbar Hashmi, Dr. Subhash Hashmi, we are working day and night to make this program successful and to get you your seat very point. So in future also, we will plan further CMEs, CPDs, and webinars. And I request all of you, please be with us, join us, and support us. Thank you for your registration. Now the clinic is to start. Hope that you all will enjoy and encourage you all people that are supporting us. So I'm very thankful to all the speakers, all the delegates and our Elite CME Academy. So once again, we all thank you very much.
Thank you, sir. So we'll start with the introduction of our first speaker, Dr. Sadir Qureshi. He's an MBBS graduate from Government Medical College of Aurangabad. He has done his TPMJ Medical College and Sasun Hospital, Pune. His CNB from Asha Hospital, Hyderabad. He is currently Director Consultant Psychiatrist at Prerna Hospital that is located in Chhatrapati Sambhajinagar. He is an Associate Professor and in charge of Department of Psychiatry at Indian Institute of Medical Science and Research. So, any further delay, I hand over the mic and to Dr. Sadiq Rafi sir for conducting his talk on psychiatric complications effect of COVID-19 pandemic.
Thank you so much, Dr. Zubair sir. I'd like to thank Dr. Shafi sir and all the committee members of the Elite CME group for giving me the opportunity to talk on this topic. This is a very important topic, and I'm again very thankful to all the Elite CME for giving me the first as the first speaker. So usually psychiatrists are kept usually kept at the back. So very thankful for that. So we'll start with the presentation. So what will be the flow of presentation? The first thing is that we should know what we know from our background studies, our uh, uh, related structures. Then what we have researched. So after the COVID started in 2019, so what was the research related to mental health issues? We will talk about that and what we have faced practically during the COVID and in the post-COVID era. So I will directly start my presentation. My talk will not be concerned with the COVID thing, but it will be basically the psychological impact of COVID on the people's mind. Then I'll be sharing my few experiences and I will talk about the future implications. So what we know. So as you all know, everything, the brain is at the center of everything that we do, that we think, that we analyze. So whenever we talk about COVID, the basic issue was related to anxiety. So let us understand where in the brain the anxiety lies, or from where the anxiety is generated, and which are the centers in the brain which generate the anxiety. So basically, when we talk about the anxiety, so the anxiety is basically two things. First is the first is the it has two components. One first is fear, and the second is the worry. So basically, the fear consists of uh, panics and phobias, whereas the worries include anxiety, uh, apprehension, then expectations and obsessions. So basically, we construct the anxiety, construct the phenotype of anxiety can be divided into fear and worry. So which are the brain areas and brain circuits which are associated with these two components of anxiety, that is fear and worry. So when we talk about fear, that is the basic, it is the amygdaloid circuit or what we call as the limbic system. Whereas when we talk about worry, which includes anxious misery, apprehensions, expectations, and obsessions, basically it is the corticostriatal thalamic circuit. Basically, the circuit involves the cortex, the midbrain, as well as the thalamus. Where in the brain the fear lies? Whenever we talk about COVID, we usually talk about fear. So basically, in the fear is basically in the hippocampus and the amygdaloid regions. There are areas in the part of the limbic system which we call as the amygdala, and it is associated with the orbitofrontal cortex and the anterior cingulate cortex. These are the two areas where each and every anxiety, whatever may be the form of anxiety, it is located or it is generated from these areas only. And overactivation of these areas results in anxiety and depression. Now, one more area in the brain which is very, very important, it is called as the hippocampus. What does the hippocampus do? It has all the fear memories. For example, if a child is there in the childhood, he has suffered uh, uh, a fear of going in higher places or heights. So that memory of heights is incorporated or kept in the hippocampal areas. So all the memories which are related to fear or emotional memories, they are located or they are the area is the hippocampus. So whenever in the future also we will go into the heights, the same memory will be generated and the fear will start or the anxiety will start. The same has happened post COVID, where there was a fear, and later on this fear which was kept in the hippocampus as a emotional memory was has resurfaced, and people have started suffering from lot of anxiety and lot of depression. So this is the brain area. Now, when we talk about the anxiety and depression, there are certain neurotransmitters which are very, very, very important. So this will include the serotonin, which is the 5-HT, then the GABA, the glutamate, the norepinephrine, then voltage gated channels, then CRF. What is CRF? Is cortical releasing hormones, the HPA axis. So whenever we are under stress, there is activation of the HPA axis, which results in the release of corticotrophins, and these are the stress hormones. Now, let me introduce to one concept of neuroplasticity. So what is neuroplasticity? Whenever in the brain, certain circuits are reactivated and activated repeatedly, so they get strong and strong. So when the fear circuit, when what happened in the during the COVID, there was fear, there was apprehensions. So repeatedly these circuits were activated. So in future also, uh, whenever in the future also, whenever people face some form of stress, the same anxiety erupted. So what was the post COVID area? It was basically filled with anxieties, lot of depressions and lot of anxieties. So brain plasticity, brain was because the fear circuit was very much strong during this period from 2019 to 2022. Now also when people face a small amount of stress or small amount of apprehension, the same circuits get reactivated, and we are seeing a lot of patients who are more prone for anxiety. This is the same thing. Whenever we talk about anxiety, we talk about uh, when we talk about loss. For example, if we are facing some stress or we are facing some loss, what is the how we respond to it? Now, each person reacts to impending death or loss in his own way. There are similarities in the psychosocial responses. So, there was a person, Dr. Alexander Kubler-Ross. He gave 5 stages of this impending loss. First is denial. When we say that no, this cannot happen to me, or this is not real, or it feels surreal. Then there is anger. Why this happened? Why this has happened to me? Why did I why did I do wrong? Why God has punished me? Then then we start bargaining कि हम ऐसा कर लेंगे तो ठीक हो जाएगा, हम कुछ और कर लेंगे तो ठीक हो जाएगा. We start bargaining with our fate. We start bargaining with God. We start bargaining with the problem we are facing, and gradually this bargaining converts into a form of depression where our interest in things go down, our mood becomes very, very low. We feel hopeless, we feel helpless, and over a period of time, the coping skills we generate, we take help from the people, and finally we accept the problem. So the same thing has happened in the post-COVID era. Now, we have a- Now, what are the phases? So, whenever we face the COVID, there was acute phase during the outbreak. As you all know, what were the issues we faced? It was fear. What will happen? It was denial. No, no, this is happening only in the Western countries, or it has started in the China and it will not come to India. Then there was anxiety. What will happen to us? What will happen to our job? What will happen to our children? Then there was, because of the excessive thoughts, there was insomnia. People were not able to sleep. Then there were dissociative symptoms where people became very, very panicky. Then there was, because of the stress, there were suicidal ideas. What will happen? We don't want to go into the isolation. So suicidal thoughts and suicidal attempts we have seen. Then because people were isolated, they were stressed. So people thought that, okay, we'll start with substances like alcohol, cigarette smoking, and that will relieve our tension, stress, anxiety. And relapse of pre-existing mental illnesses. Those people who were previously suffering from mental illnesses, they resurface. So all these things we have seen in the acute phase of the outbreak. Now, uh, then what? Second phase was the long-term phase of the after the control of the outbreak. So there was grief. Many people lost their near and dear ones. They were in a state of guilt. What could we have done differently? So our parents or our relatives could have been saved. There was, this is called as the survivor's guilt. Those who survived the COVID pandemic, they thought we could have not gone out, or we could have given the vaccine, or we could have shifted our patient a bit early, and they landed up with a severe grief. Then there was depression. Then there was substance abuse. There was again the pre-existing relapse of the pre-existing mental illnesses. PTSD is very, very important. Disorder, which includes re-experiencing the same symptoms again and again, and somatization disorders. Now, what was the vulnerable population post-COVID who could have suffered from mental issues? They were children, because they were not going to school, they were isolated, they were not going out for any form of play. Then there were senior citizens, again, social isolation, their pre existing physical conditions, then pregnant females, persons with disability, homeless individuals, people who are with poor social support and low socioeconomic status. Then patients who are on life-threatening chronic conditions like cancers, renal failures, asthma, COPD, and immunocompromised persons, especially post-chemotherapy, radiotherapy patients. History of severe mental illness and wandering patients. These were the vulnerable population. No? What happened after the COVID? What was the research? What were the things in which we researched how the COVID and the post-COVID era has affected the our mental health? So there are, I will in the next 3 to 4 slides, I will be presenting the few of the articles where they have studied the long-term effect of COVID on mental health. So this is one of the study in the Journal of Affective Disorders, where they have the study has shown that long-term prevalence of anxiety, depression, PTSD, and sleep disturbances were significantly increased as compared to the general population. One more study, this was in Helion. The study was conducted in the psychological well-being of young adults. So the young adults from both developed and developing countries were affected by the pandemic. The study shows that mental health should be prioritized globally, and psychological well-being and mental health should be kept more important than the physical health. This was again the one of the articles which shows that what was the long-term effect of COVID-19 pandemic on 5 mental and psychological disorders. So they studied anxiety, they studied depression, sleep disorders, stress disorders, eating and excretion disorders. What they concluded in the study, they concluded that the epidemic environment has a long-term effect and negative impact on people's mental health and psychological conditions. It has negatively affected the psychological conditions of the people. Therefore, whether the epidemic is receding or still it is continuing, mental health and psychological health is more important. Another article, this was in Elsevier's, the impact of COVID-19 pandemic on eating disorders. So they showed that the eating disorders has increased. Again, one of the important disorder is the post-traumatic stress disorder. Now, this was a very interesting study which was published in India Today journal. This was conducted by Science Lab, and it has shown the mental disorders prevail even after 3 years after the COVID-19. Like this study was conducted in 2022, after 3 years post COVID, and it has shown what was the percentage of people who were suffering from mental illness. As you can see, the maximum is in the UK, South Africa, Brazil. India is on the fifth position. 30% of the patients, even after 3 years post COVID, also they were suffering from mental illness. The same study shows that in the post COVID era, mental distress and mental disorders were very common in females and Gen Z. Gen Z in the sense those who have uh, born in the 2000s. And as you can see in the chart, globally it was a bit less, whereas in India the females were suffering more and males were suffering more. And if you see the age-wise distribution, younger the age, more was the psychological impact of COVID. So you can see in between 18 to 24 years, it was around 50%. So almost two in one adolescent or young person was suffering from psychological illnesses, anxieties, depression. So as the age increases, the prevalence of mental illnesses post-COVID was decreased. This study again conducted the correlation between the education and the professional effect of mental health in India in the post-COVID area. So you can see in the lower part of the presentation here, those who were having only primary education, they were the more sufferers as compared to those who are at a higher post. Maybe those who are having primary education, their professional there were professional insecurities, whereas those who are having a higher qualification and higher post, they were a bit relaxed as far as finances were concerned. Now, let's come to what we faced as a psychiatrist or as a practicing doctor. What we have seen. So, what we have seen is stress. So, let us understand what is stress. So, what is the stress? Stress is defined as the internal state which is caused by any physical demand, environmental factors, and situational factors. So, what were in the case of COVID and post-COVID era, it was physical demand. We were asked to be isolated. We were asked to be inside the rooms. Then there was environmental factors. A lot of our movement was very restricted. Social situations had changed. There was isolation. People were isolated in the home. They were not going out. Most of the work was done from work from home. Then and the event is evaluated as potentially harmful, uncontrollable, and exiting our resources for the same. Now, this was the classification which was given. What is the reaction of people or reaction in the post-COVID era? So this is from the DSM, but ICD and the DSM criteria. So the most common was the post-traumatic stress disorder. Then there were adjustment disorders like deep depressive reactions, prolonged depressive reactions. So depression was the most common, and anxiety was the most common. Mixed anxiety and depressive reaction. Then predominant disturbances in other emotions, predominant disturbances of conduct. Conduct was seen usually in the adolescent people who were not following the social rules. They're not going to the schools. They are not going to the colleges. I have few cases to discuss. In the future slides, I will you'll understand it more better. This is again a very good study, which is telling about the anxiety, depression, and the anxiety, depression, and eating disorders pre and post COVID, okay, or peri COVID. So as you can see in the pre-COVID era, 9% or 8.9%, there was anxiety symptoms which increased in the post-COVID era to 22%. The depressive symptoms were around 9%. Again, it increased to 18%. And eating disorder was in the pre-COVID era was 15%, which was increased to 23%. So this study again shows that in the post-COVID era, anxiety, depression, and eating disorders, these were very much increased. Now, what are the psychological impacts? Now we're coming to the important few slides. Anxiety. So anxiety has increased up to 25%, which was reported by WHO. Studies suggest that psychiatric consequences of COVID-19 are widespread and they persist probably even 6 months beyond the illness. One thing I want to clarify here: whenever we face any disaster, the physical effect of the disaster lasts for the when the disaster continues, but the psychological impact can continue for years. That's the same thing has happened with the COVID. COVID ended in 2022, but even today also we are seeing the effect of COVID in the form of school refusals, in the form of increased substance abuse, in the form of increased anxiety rates, in the form of increased depression rates. So again, depression is the second most common. Primary cause was social isolation, the loss of routine, economic stress. All this resulted in depression. Panic attacks. So, what is a panic attack? It is characterized by recurrent, unexpected attacks of severe anxiety, like restlessness, palpitations, sense of impending doom, feeling like I'm suffering from a heart attack. So these symptoms have significantly increased in the post-COVID era. Phobias. So, there was a lot of phobia regarding fear of infection. If I go out, I will have infection. Now also we see people who are using a mask. Even there are no compulsion for mask. They feel that if I go out, if I touch someone, there will be a sense of infection. So phobias have increased. OCD. As you all know, there was a pressure for us for hand hygiene. So people from post-COVID era, especially students, they have become thoughts of contamination are there. They have started washing their hands repeatedly, and OC symptoms have been seen. Grief and loss. This is very, very important. The loss of loved ones due to COVID-19 has resulted in profound impact on mental health, leading to grief and trauma, especially those who have lost their parents, those who have lost their near and dear ones, very close family members. Grief and thoughts about why this has happened to me, what could have I made a different, whether I had chosen a wrong hospital, whether I had shifted the patient very late. All these things thoughts still uh, trouble people. As I told you previously, PTSD is post-traumatic stress disorder. So this was one of the studies. It has shown 19% of physician-reported symptoms consistent with PTSD. It was higher in female, uh, older physicians, and trainees. Sleep. So sleep disturbance is again very, very common, especially in children. This is again very important academic and social challenges. What we have seen is the surge of students uh, means addicted to screens. Most of the things they are doing is on the screen. For example, they are not attending the colleges, they are not attending the schools. Most of the time they are on the online with either with the social media or with the online gaming. So that has changed. And this is the same thing. Increased screen time. So especially in children between 4 years to 12 years, there is increase in the screen time post COVID. Yeah, as I told you, eating disorders, these are very, very common. These are common. These are most of the studies of eating disorders are done in the Western countries. In India, it is relatively less common. Suicide and suicidal thoughts. Again, these are very, very common. Unexpected behavioral changes during the COVID-19 pandemic may have contributed to increased trend to suicidal attempts. Domestic conflict, violences, financial loss, anxiety and depression, and pre-existing mental illnesses and mental conditions. These are the risk factors for self-harm. This is again very how the COVID-19 and the post-COVID-19 era has affected the elders. So, as you all know, in the old age, there is a decrease in the immune system. What happens is there is a stress. The stress leads to activation of the HPA axis, increase in the levels of cortisol, and this increase in the level of cortisol increases the pro-inflammatory cytokines, and these pro-inflammatory cytokines result in uh, increase in the inflammation and vascular changes in the brain. These old people and geriatric people are already prone for vascular events. So all these has result in hyperinflammation and deterioration in cognition. What happens with children and adolescents? So we have behavioral symptoms. Then maybe what was the behavioral symptom changes in children? It was reduced physical activity, increased sedentary habits. Most of the children were habit of sitting idle at home, so that continued. Increased screen time, as I have previously mentioned. Increased intake of alcohol, cannabis, and smoking. Increased use of social media, television, and smartphones, and gaming disorders. Then what was the psychological impact? Anxiety and depression were very, very common. It increased from 10% to 30%, and a greater severity of anxiety symptoms among females and adolescents. Then there was sleep disturbances, then increased duration of sleep, reversal of sleep patterns. Most of the adolescents, what we see, they are awake in the night and they are sleeping till afternoon or even in the evening. What was the effect on the quality of life? So that was the overall the quality of life decreased. Uh, Most of the adolescents shows negative behavior. They were social isolation was seen. Lot of conduct features and substance abuse. Now, these are the few cases which I have experienced. A 9-year-old boy was brought by the parents with decline in the academic performance. On we evaluated the patient, we did the intelligent question IQ, which was normal. The understanding and comprehension of the language was very, very good. What has happened that during the lockdown between 2019 to 22, most of the online classes were conducted, and that this boy was unable to attend these online classes, and finally he landed up with a specific learning disability. So this was the direct impact of COVID and COVID-related events on the patient's health, mental health. Again, a 17-year-old boy was brought by his mother. This was the case seen by me around 10 to 15 days back only. Again, with poor academic performance in the and which was increased in the post-lockdown period, and there was decrease in these percentages. Screen time, this boy was around 12 hours, and he was addicted to the game like Free Fire. Whenever the parents used to take the mobile, he would become aggressive, even at times beating the family members and becoming very aggressive. No, this is what we have faced. Now, what is the future? See, such type of disasters can come at any point of time, which is not in our hands. So, what are the things in our hand? We'll see. So, basically, what we want, we want to reduce our stress levels. So, what are the things that we can do to reduce our stress levels? Is the four A's. First A is avoid. Avoid in the avoid part. Take control of your surroundings. Avoid people who bother you. Learn to say no. Which part of your list? Completing the list and doing the each and everything is not a compulsory thing. Then alter. What we can alter? Respectfully ask others to change their behavior. Communicate your feelings openly. Manage your time better. Set priorities and work hard. Uh, uh, State limits in advance and rehearse their success. Accept. Talk with someone. This is very, very important. Forgive and forget. Don't keep the burden of people's behavior on yourself. Practice positive self-talk. What happens is whenever we are facing any stress, we talk negative about to ourselves only. We think negative, we talk negative. So practice positive self-talk. Learn from your mistakes. Then adapt. Adapt to your standards. Practice thought stopping. Reframe the issue. Adopt the mantra. Create an asset column. Look at the big picture. Take care of self, avoid drugs and alcohol, find support. This is very, very important. Connect socially, not on social media. Take care of yourself, eat healthy, well balanced diet, exercise regularly, get plenty of sleep, at least 6 to 7 hours on time. Not that you should sleep late, get up late. You should sleep 7 to 8 hours in the night time only. Give yourself a break if you feel stressed out. Maintain a normal routine. Stay active, exercise. This is very important. At least 150 minutes of exercise in a week will help you to reduce your stress. Write whatever is the problem, then you will find the solutions. Do something you enjoy. Develop a hobby. Relax your body. Let your feelings out. Focus on the present. Don't focus on the mistakes you have done in the past or worry about the future. Focus on the outside world. The take home message, having a fixed routine is very, very important. 7 to 8 hours of sleep, healthy food habits, engaging in some physical activity, time management skills, sparing some time for hobbies, avoid substance abuse. Spiritual connection is very, very important because when we attach spiritually to our creator, the levels of stress, the level of cortisols, they come down and we feel happy, forgive and forget, and help each other. So this is the JPMR relaxation exercises that you can it is easily available on the net. You can see it is just a breathing exercises which will decrease the sympathetic tone and increase our parasympathetic tone, in which we will get feel relaxed. So if anyone is feeling anxious or there is lot of worries, this can be performed on the YouTube. It is available on the YouTube freely. You can go and see. So nothing is permanent in this world, not even stress. So be happy, enjoy your life, and thank you very much.
Thank you very much, sir. I would like to request our director, Dr. Shafi sir, to kindly felicitate Sadiq Qureshi sir for his beautiful talk. So this beautiful presentation about the most important effect, uh, psychiatric effects that people are facing around the world due to COVID-19 pandemic was delivered to you with the help of ClearNet, that is our presenting partner. I request Ritu Madam to kindly introduce ClearNet to our delegates. So, Madam, over to you.
So, good morning, everyone. As we have already come across a long way, so uh, I will wholeheartedly welcome all the dignitaries present over here. And as a declared moderator of this session, I'm Rituparna. I'm very proud that Klarnet stands as India's most relied upon digital platform, offering a multitude of enriching services for the doctor. And also, it's with great pride that Klarnet serves as a digital partner for this online event hosted by Elite CME Academy in association with JUICE Indian Institute of Medical Science and Research, Jalna. So, without wasting any further minute, I would like to hand over the session to Dr. Zubair sir for the further coordination. And thank you once again for giving me the opportunity. Thank you.
Thank you very much, Madam. ClearNet is definitely a very good help for the doctors who or the institutes who want to, conduct such a programs online. Would like to introduce our next speaker, Zahir Abbas Shah. From the technical delay. So, Zahir Shah sir is a very renowned physician in Chhatrapati Sambhajinagar and in Marathwada district for his great work in tuberculosis and chest diseases. Uh, Sir he has done his MBBS and after that he is diploma in tuberculosis and chest diseases and is topper of his course. He has also done diploma in allergy and asthma from Vellore, Tamil Nadu. Sir is endorsed by American Academy of Allergy, Asthma and Immunology. He has delivered numerous talks during the COVID pandemic. The awareness talks of using masks, of how to manage your illnesses in the COVID pandemic. He is now renowned as a national and international speaker. He has got many international paper publications. He is a committee member of National Conference of HFCONS 2000. He was member in 2011. He is an accredited speaker and he is life member of many of the academies and that are functioning in the medical lobby. So I would now like to display his presentation. I now request Dr. Zahir Shah to kindly take over the mic for his talk on COVID-19 respiratory sequelae, a lesson learned.
So, good morning, everyone. At the outset, I'm very much thankful to the Elite team of this Elite CME Academy for giving me an opportunity to speak about this important topic, this respiratory sequelae and the lesson learned. So, myself, Dr. Zahir Abbas. So, without wasting much time, I will directly start with the topic. Expected all. First of all, I request you all to put your mic on the mute mode so that it will not come to our ways. So directly, I will begin with the top COVID-19. COVID, Co is corona, VI is virus, D is disease, and it was detected in December 2019. That's why it was COVID-19, and it was caused by novel coronavirus SARS-CoV-2. So if you see this image, the, during the at the start of this pandemic, we were masked and caged during this pandemic, and the animals were roaming freely. So before that, we were roaming freely, and the animals were inside the cage. And during this pandemic, if you see the third image, the animals were visiting our human park. Now it was pandemic for the whole world, but for us doctors, for physicians, case physician, and for rest of the clinicians, it was an infodemic. So we were the papers were piling up, and we were drowning, and we were in need of help because so many thousands and lakhs of people were coming on daily basis. So scientists were also worried and they thought and they were talking with each other that if we don't flatten the curve, there will be about 50 million COVID papers by the end of this year, means 2020. So the scientists were also drowning in the COVID-19 paper. So it was an infodemic for us. Many CMEs and webinars were taking place during that period on daily basis, on day-to-day basis. Most of the times, the webinars, number of webinars were 4, 5 in a single day. So my condition was like this superstar, which webinar or CME is today. So I was having some memory loss during that period. Now, in COVID-19 period, we had the government imposed a lockdown for the benefit of the people, for the benefit of the masses, and it has its pros and cons. So if you see during lockdown, the most busy and fast moving city, Mumbai, it appeared silent and it gave a beautiful look like a foreign country, Amchi, Mumbai. After that, if you see, if you consider the period of World War II, it lasted for 6 years. And since then, the Wimbledon Championship was never cancelled, but it was cancelled for the first time during this COVID-19 pandemic. For the first time in the history of railway, in 167 years, the train failed to run on the track and it was not never stopped. And the city's lifeline was never stopped even during the two World War II war and World War II. And after the attacks of 2006, 2006 and 2008 attacks, it was never stopped. But during for the first time in the history of 167 years, the train failed to run on the track. So snowy mountains were visible from Jalandhar. So if you see the Jalandhar, the distance of Himalayan mountains from the Jalandhar, it is 200 kilometers, and it was exactly seen after 30 years. So for the first time, so this lockdown turned as an air purifier as well. If you try to see now from the Jalandhar, the Himalayan mountains from the Jalandhar, it will not be able to see. So due to the increased amount of pollution and the high index of air quality index. Now I always say that history repeats itself. Respected all, in 1720 we had a plague that was called as Great Plague of Marseille, and it was the cases were transmitted. The cases were found in the France, the city of Marseille. So the Marseille was the city of France, and the cases were reported from that. So that it is called as Great Plague of Marseille. In 1820, we had a pandemic of this cholera, and it took place in India, Japan, Saudi Arabia, and deaths were in lakhs in Thailand, Indonesia, and Philippines. In 1920, we had a Spanish flu, and deaths were in millions. So I will elaborate this pandemic in my next slide. In 2020, so exactly after 100 years, so the pandemics are taking place. So 2020, we had this COVID-19 that was caused by novel coronavirus. So, respected all, the Spanish flu influenza started in 1918. You will not believe me. It was the one of the deadliest pandemic in human history. It infected one third of the world's population. Around 500 million people were affected. World War One was just over, and the soldiers were returning to their home. And the deaths due to World War One was 40 million, and the death caused by this pandemic was 15 million. Young people were the victims of cytokine storm. If you try to see the potential of this H1N1. So H1N1 is not a that much lethal strain, but it caused deaths and it affected young people. Why? Because due to famine, poverty, overcrowding, malnutrition, and secondary bacterial infection caused this cytokine storm. It affected young people. It killed young people. And if you see this name, Spanish flu. So it never took place in Spain. It started from China, Spanish flu. But it is a misnomer. So Spanish flu, but the Spain was the only country that was reporting the real number death in due to the Spanish flu influenza. That's why the name comes from the Spanish flu influenza. So the soldiers were returning from World War One, and this disease managed to enter inside our country as well. So 102 years before COVID-19, India braved the Bombay fever, killed 17 million deaths. That caused 17 million deaths in India as well. And the disease was named as Bombay fever. So if you see the paper of this researcher David Arnold, he wrote in his paper that death and the modern empire. So during this pandemic as well, second wave was the most fatal wave. So during COVID-19, COVID-20 also, we told the people, we requested the people to have this preventive measure, to take the preventive measures, apply mask or apply this hand washing and this thing, non-pharmacological logical measure. The people failed and we had paid the price of it. And during second wave in 2019 also, we had more deaths. So during this Bombay fever or Spanish flu influenza, Mahatma Gandhi ji was 49-year old. He also suffered, and fortunately he recovered from this Bombay fever or Spanish flu influenza. 17 million Indians they died due to this, and this was having most impact in our country. So this delayed or this was having an economic impact on our economy, and this delayed the freedom fight movement of our country. Now, coronavirus, if you see, it is a large family of viruses. So that the illness range from simple cold, common cold, to more severe disease, and it was caused in 2003. It was called as SARS-CoV. So severe acute respiratory syndrome. It started in again in China in 2002, and it nearly killed 650 people, and it was transmitted from civet cats or from the bats. In 2012, we had this Middle East respiratory syndrome and COVID virus. It killed 8,800 people, and it started in Saudi Arabia, and the camel, it was transmitted to human beings from the camels. In 2019, we had this novel coronavirus. So it was first detected in Wuhan, in China, and it spread out to the Japan, Thailand, and South Korea. So if you compare this COVID-19 virus with SARS-CoV, so it is a single stranded RNA virus. It is 25 times bigger than SARS virus. So why, how the name crown, this corona comes? So it is a Latin word. It means crown-like appearance. So the glycoprotein, the spikes of glycoprotein, it looks like a crown. That's why coronum. It is a Latin word actually, and this coronum means for this crown-like. In the envelope. So if you see the size of this virus, if you take a cross section of human hair, so 2000 coronavirus can be accommodated in a cross section of a human hair. So it is a micron in size. So size of the coronavirus is 60 to 120 nanometer. Now coming to the gender, it is not sparing any individual. It fixed from pediatric age group to the geriatric age group, and definitely, if the corona or COVID-19 has not discriminated since it has started on the basis of age, race, religion, and sex. So the COVID-19 don't discriminate. Now, coming to the diagnosis of this COVID-19, so as we know, we have done this RT-PCR testing. It was very specific. It was having high specificity and high sensitivity, and the rate of false positive and false negativity was less as compared to this antigen antibody test kit, which we have used as a spot diagnosis. Now, coming to the symptomatology of COVID-19, so the coronavirus was presenting with the history of this fever, high grade fever, dry cough was there. Sometimes it was associated with sputum production. Fatigue, malaise was there. Shortness of breath or breathlessness was there. Body ache, sore throat, headache, chills, and nausea, vomiting, nasal congestion was there. Some atypical symptoms were also there. Anosmia and loss of taste were there. So these were the milder symptoms. In severe cases, it was having the severe symptoms. So as per this WHO organization, 80% of the people or patients, they were mild cases or asymptomatic cases. The 15% of the cases were only severe and they required oxygenation, and only 5% cases were critical and they required ventilation. If you see these again, 14% of the patients had pneumonia, 5% patients suffered from septic shock and organ failure, and 2% of the cases were fatal. So a spike in pneumonia cases were first sign of this new coronavirus of outbreak in China. So in this, what happened exactly? There are 300 million alveoli on the right side on the right lung, and 300 million alveoli there in the left lung. So air sacs become filled with fluid, pus, and cell debris. So that limited the ability to take in that hampered the oxygenation, and that caused shortness of breath, cough, and other symptoms as well. So predominantly the pneumonia was basal, peripheral, and subpleural region. So supportive care definitely we gave. So what type of damage can coronavirus cause in the lungs? So ranging from small common cold to pneumonia, acute respiratory failure, acute respiratory distress syndrome, septic shock, also lasting harm to the lung, and super infection or secondary bacterial infection, and this thrombotic activity, because the virus is once the virus enters inside our body, it causes profound inflammation, and it is having this pro thrombotic activity. So it was this venous thromboembolism as well. Now, if you see, so this is a severe case of this COVID-19. There is a bilateral patchy nodular opacities are there, and these multiple ground glass opacities can be seen in this B insect or figure. So peripheral patterns of the opacities without subpleural pairing. In C, you can see a 71-year-old male shows consolidation in the peripheral right upper lobe and a patchy area of ground glass opacity consolidation, and intra and interlobular septal thickening was also observed. Again, if you see, the first on my left hand is early stage. So subtle opacities are there. In number two image, advanced stage is there. So the opacity has increased definitely. Bilateral lung opacities, parenchymal opacities are there, and they are nothing but the ground block opacification with consolidation. In severe, there is a total whiteout lung appearance is there, and in resolution phase, you can see in the fourth image that the consolidation is resolved, leaving some residual or curvilinear areas of density. So residual radiological abnormalities was dependent on some factors like age. If the age of the patient is more, if smoking history is there, if comorbidities like hypertension, diabetes, and other comorbidities are there, and lower SaO2. So it was tending to be there if these factors are there, and with secondary bacterial infection as well. Now coming to the treatment part, there was no specific treatment. As we know, we have given the supportive treatment, and we have tried our level best during this pandemic. So oxygen support, conservative fluid management, and antiviral we have given. So before I proceed forward, before I start next slide, so can you judge what is this picture is depicted for, or what is this is nothing but a ventilator which was used in the past. So it was the first ventilator which was which was invented in 1950. So it was there was a polio epidemic or polio pandemic was there in 1915, and this is the Boston Children's Hospital picture. It was multi-person negative pressure ventilator. So it runs on negative pressure. Whatever the ventilator we are using nowadays, so they are positive pressure ventilators are there, and these are the multiple ventilators you can see in a hall. So what it ran on the principle that the person or the affected person was made to lie or made to go inside this cubicle or this box, and only the portion from the neck was visible. You can see the lady is feeding her husband some food, and the patient is completely inside this iron box. So it was called as iron lung. But this was taking so many space, and there was paucity of space. So after that, there come a chest cuirass. Again, it was a negative pressure ventilator, and it was like a turtle shell. It was called as turtle shell ventilator was there. So these two ventilators were invented first time in the world. So what are the post-COVID sequelae or post-COVID complications? So there is a term post-acute sequelae of SARS-CoV-2. It is called as PASC. So it is also called as long COVID or long hauler syndrome. So this syndrome is nothing but the poorly defined syndrome that includes a range of new, recurrent, or ongoing health problems. So that can definitely last for weeks, months, or years. So we cannot predict so for how many years the post-COVID sequelae will remain after infection with COVID-19. And you will not believe me, 10 to 35% of the infected individuals at present, also they are infected, they are having this post-COVID, post-acute sequelae of SARS-CoV-2 or long COVID. 2 million people at present are experiencing the symptoms, the agony of this long COVID. Now coming to this, what are the symptoms of this long COVID? So the cough will be there, dry cough will be there, the breathlessness will be there. So the typical breathlessness after walking or climbing the stairs, or exertional breathlessness, fatigue is there, chest tightness, and wheezing is there. Sometimes it mimics obstructive airway disease like bronchial asthma or other obstructive airway diseases. Now coming to the post-COVID, the abnormalities which are seen in the CFT or as well as spirometry. So there are heterogeneous abnormalities. So there could be reduction in the total lung capacity or lung volume. There is definitely reduction in the 6-minute walk test, and there is reduction in the saturation, reduced diffusion capacity for carbon monoxide, VLCO. Total lung capacity is also reduced. So if you see over here, what are other complications, what are post-COVID respiratory complications? So pulmonary fibrosis. Typically, after severe respiratory tract infection, there is a pulmonary fibrosis, and that takes place, and there it is seen in that the ground glass opacification or ground glass opacity with reticular pattern is the commonest finding. There will be interlobular septal thickening. There will be mosaic attenuation. It may or may not be associated with bronchiectasis or traction bronchiectasis. Now, what are the thing that is responsible for this fibrotic lung disease? So it is possible that various insults such as long use of ventilator, so ventilator induced lung injury, bacterial infection, hyperoxia contributes to the post-COVID fibrosis. We have some neurological manifestation and we call it as a brain fog. So the cause behind this was endothelial dysfunction, coagulation abnormalities. The virus is having prothrombotic activity, direct viral transmission through the olfactory nerve. So this was responsible for this anosmia or hyposmia or loss of smell, and hypoxic brain injury and disruption of the blood-brain barriers are postulated to play a role in the neurological manifestation of the patient. So loss of taste and smell, meningitis, encephalitis, cerebral vasculitis, and myalgia, where the all result from direct viral invasion of the nervous system. Now the whole thing revolves around this orchestra or this picture. So this is nothing but the where the interstitium is there. So here there is an interstitium, and this is the picture of the alveoli. So here the gaseous transport takes place. So the O2 inside enters inside our body, and CO2 is taken out of the body. So what happened? So this part of the slide, this of the part of the picture is normal. There is the type 1 pneumocyte, type 2 pneumocyte, alveolar microphages are there. But if you see the another part, so there happened that there was inflamed endothelium was there, and it was due to this activated endothelial cells. Some protein release was there. The microthrombi formation was also there, and during this, there was this fluid field or pus field alveoli were there, and there was release of chemical mediators of inflammation, and that caused this cytokine storm. So this is how this is in short the orchestra or the picture of this. So now post-COVID or long COVID, it starts the symptoms take care from the head to toe. And if you see the hair loss in 25%, hearing loss will be there, dyspnea, nausea is there, joint pain will be there, headache will be there most of the time, 44% of the people, and attention disorder, anosmia, fatigue is there, this ageusia or cough, polypnea, chest pain, all these symptoms are there, and nowadays also the patients suffering from long COVID, they are experiencing these symptoms. Neurological encephalopathy or Guillain-Barré syndrome, cardiology, myocardial injury, arrhythmia, shock, these are the there. But I'm more concerned about this pulmonary acute respiratory stroke syndrome, and whatever we have seen this fibrosis, venous thromboembolism, pulmonary embolism were also seen. We have also seen this fungal infection. So what happened, due to this fungal infection, they had an effect on the immune system of the patient, and they weakened the body's defense against this fungi. So what happened? So we must have heard this white fungus, black fungus, and yellow fungus. So the white is nothing but the invasive candidiasis, mucormycosis. The spores are black, so that's why mucormycosis was called as black fungus, and mucor septicus was there. It was causing this yellow fungus. Now coming important part of the today's talk is lesson learned from this COVID-19 pandemic. So lesson learned, this study was conducted and was published in this renowned journal for emerging microbes and infection. So lesson learned 1 year after SARS-CoV-2 emergence. What happened exactly? So during this pandemic or before this pandemic, there was a presence of larger reservoir of coronavirus in bats and other wild animals. and there was culture of mixing and selling them in urban markets of hygiene. So habit of eating exotic animals, that too with suboptimal hygiene, and there was highly populated areas where there was rapid and frequent. They were the frequent air traveler, and these areas were perfect ingredients for brewing the rapidly exploding epidemic or a pandemic. So there was during after the first year itself, we had some difficulties of mass testing, labor intensive contact tracing. Importance of compliance to universal masking and low efficacy of antiviral treatment was there. So again, what lessons we have learned from this COVID-19 pandemic, so that we increasingly we were dependent on this machine that was pulse oximeter. So I'm not against this use of this, but it was a supportive tool, and most of the time it confused in most of the individual. So whenever the patient saturation was 70 below 75, it was not working well, and the only thing the only reliable thing was this ABG, arterial blood gases. So in darker skin patient also, or black skin patient, so it confused the clinician. So there is a limitation of this pulse oximetry, and the accuracy of this pulse oximeter varies from person to machine to machine. So and again we use this technique awake proning. It is a beautiful, and whenever this it is used particularly in awake patient, so 30 minutes you have to prone the patient fully prone on stomach. After that 30 minutes you have to ask the patient to lie down on right side 30 minutes, or lie down on the left side, and after that the patient will sit or sleep for 30 to 60 degrees, and for this 30 minutes. So only thing, the precaution or this contraindication was there, whenever you are having frequent seizure or pregnancy is there, so it should not be used. Now you must have seen this, that during this pandemic, the family physician and other people also, those who are not related, or those who are not involved actively, or even though they were involved, so there was some sort of overuse of HRCT chest. So there was one paper, are we really ordering too many CT scans? So this paper concluded that unnecessary CT scan exposing the patients to excessive radiation and cancer cases could spike as a result. I have come across this paper. So knowingly, unknowingly, chest CT scans were performed in 71 lakh people in US, and out of that, 4,100 people now are having the highest risk of cancer, and the estimated rates were more in children and females. Now coming this to use this non-pharmacological measure to mitigate the transmission of this COVID-19. First of all, we use this mask to avoid the transmission of the disease, because whenever the infected patient coughing, sneezing, talking, shouting, or laughing, the viruses were releasing inside the environment, and you will not believe me, one sneeze shower contains 40,000 droplet nuclei, because the disease was spreading with the help of droplet nuclei. And after these 40,000 nuclei, once they are released in the environment, so they are having capacity to travel with the speed of 200 miles per hour. And one droplet, this sneeze shower, may contain 200 million viral particles as well. So one cup out contains 3,000 droplet nuclei, and it can travel with the speed of 50 miles per hour. Again, one cup out may contain 200 billion viral particles. So this is the thing. So what happens whenever a patient coughs or sneezes out? So if you see the ballistic trajectory of the large droplet, so there is a one terminology, mass median aerodynamic diameter. So whatever the particle size are there, which are bigger than 100 micron in size, so they are deposited, or they are brought down to the surface because due to the gravitational force. And whatever the medium sized droplets are there, those who are lesser than 5 microns, so they are carried out to the distant places and long range airborne route, and they are transmitted through the aerosol. Now we have seen this surface contact and formite, because on the car handle, door handle, steerings, switches, staircases, lavatory seats. So the virus was found profoundly, and this has particularly tendency to survive on plastic, paper, glass, and wood for consecutively for 4 to 5 days. So this was the reference I have taken from international consensus from the pulmonologist.
again, one thing was there which was eye-opening for me, that COVID-19 patient can infect 406 patients in a span of 30 days. This was concluded by ICMR study. So that's why we have to use this protective measures, and we made the people, I also made some various videos, and I appeal the people to use, many people appeal the masses to use the protective measures to flatten the curve. Now the mask, what is mask? So mask we have, which we have used, is a French word. It means masque. So covering to hide or guard. So it is the first mask which was used in. It was made of a stone, and it was first time used in 7000 BC. It was used for some spiritual purpose. This is the mask used during the plague pandemic. So the great plague of Marseille. So the dead bodies were piling up, and they were releasing the bad odor was there. And to hide or to mask this bad odor, so there was a big like portion of this mask was there. And what they used to do, so they used to smear the handkerchief with some aroma or this perfume, and they used to insert inside this big portion, and there was only eye opening was there. So this mask typically used during the plague pandemic. Now the on screen, which whatever the mask which you are seeing is single layer surgical mask. So what, you will not believe me, being a chest physician also, mask was just a piece of paper or piece of cloth for me, and mask was only mask. I was not knowing about the various types of mask, at what time it should be used, and what is single layer, triple layer mask, N95, facial protecting piece. I was not knowing before this pandemic, and I have learned a lot from this. So I made an extensive work, and I have presented at many platforms on this mask. So COVID-19 and mask was my favorite topic during this COVID-19. So single layer mask was there. It was non-woven, and it was typically what we suppose it was for used for some food industries. It was not protective against COVID-19. So triple layer surgical mask, it is having triple layer. So middle layer is made up of with the melt blown filter, outer layer hydrophobic, non-woven, and middle this inner layer is soft absorber. So this was effective. If you see the uncovered sneeze with the covered sneeze surgical mask, so typically it was reducing, or it was reducing the transmission of the disease, and it was helpful in mitigating the transmission. So how to wear mask, I have learned for the first time. So it should be a typical fitting, and there should not be any space or any leak should not be there. So this is the picture, and which side should be on outside, the bluish side, and the whitish side inside will be there. So this also I have learned. So if you see this, the Lancet paper's conclusion, so transmission is definitely lower with the physical distancing, and with other measures like face mask using, that could be surgical mask or N95 mask, and eye protection, whether in the form of face shield or this goggles, they were associated with less infection. So N95 mask was only N95 for we people, but there were a genuine and fake mask. So during this pandemic, I learned to read, how to discriminate between this genuine and fake mask. So if we want to now again, if you want to decide whether it is genuine mask or not, so there will be a NIOSH will be applied, written over this. It is nothing but the National Institute for Occupational and Safety Health. TC will be written on this. Lot number will be there, and N95 will be written on this genuine mask. So these are the indications of the genuine mask. So this is the another type of mask which fascinated many clinicians. So respirator mask with wall, but there was a guideline afterwards. So Director General of Health Services of India, he warned that this mask with wall should not be used because it was spreading out the infection through this wall. So the exhalation was directly into the environment. So this was unidirectional exhalation wall was there, and after that the people stopped using this mask. Now coming to the certification system in short, every country is having its certification system for mask. America is having N95 mask, Europe for facial protecting piece, China is having also its certification system, and India is not having our own certification system. We use, people accidentally use their mask during jogging and running, but PGI Chandigarh came with the guideline that wearing mask creates a situation of hypoxia and it hinders the oxygen flow to the body. That's why again during jogging and running it was prohibited. We learned the reuse of respirator during this COVID-19 pandemic, and the respirator or the mask can be used 4 to 5 times after this taking this measure. Reuse sterilization part. So hot air one, you can put it for 30 minutes and in a pressure cooker 150 to 160 degrees, so that can be taken care. Now coming to this special protecting piece, N95 efficacy is equal to this FFP2 and N100 efficacy is equal to FFP3. So there were certain terminologies, respirators. So N, what is meaning of the N? That is no oil resistance is there. R is somewhat oil resistant. P is strongly oil proof, and P and R are not used for, they are used for industrial purpose. So if you see N95, the breathing resistance over here is only single plus. N99 breathing resistance increases, N100 breathing resistance and again increases. So already with N95 mask, we were for this having this, there was a claustrophobia was there and suffocation was feeling was there. FFP1 definitely, this is facial protective piece and it is a European mask that is definitely not useful for this COVID-19. We learned this aerosol generating procedure like simple nebulization or bronchoscopy procedure. So the mask should be used during this procedure as well. And PPE kits we used during this pandemic. Aerosol generating procedure, again, this kayaks was first time it was established in the first time in Kerala during this pandemic, and that gave us a good lesson, that taught us a great lesson. After that, powered air purifying respirator was there. So it was battery operated. It can be used during bronchoscopy. It was loose fitting or hooded or helmeted. It was battery powered and it was based on this HEPA. And we use afterward this mask made up of cloth and many fashionable masks that came afterward. So these are the some masks the children also using. Now, one word about this neck gaiter. So we call it as a muff. So we use this muff to protect ourselves from this winter. So I made an extensive work, and if you will not believe me, this muff can be worn with 8 different techniques. So most of the time females use it, but this wearing a neck gaiter may be worse than no mask at all. So it was the conclusion of this researcher, because it was spreading the infection and it was breaking the larger droplet particle into smaller droplet particle, and it was nothing else. It was responsible for spread of the disease. Now effectiveness of hand washing was 55%, mask usage 68%, and if you use all these 3 techniques, mask, gloves and protective gear, so 91% this effectiveness was seen with the help of these 3 things. Now this pandemic, it taught us about how to cough. It taught us about this cough etiquette, cough hygiene. So whenever we are coughing or sneezing, we can take either this soft tissue paper or handkerchief, or even you can sneeze or cough in an elbow whenever this is not there, cloth piece is not there. So cough etiquette. So what happened in Philadelphia during this pandemic, 12,000 deaths were there in 6 weeks. So that's why there was written on this van, speed spreads the death. So take measures. Now coming to the physical distancing, actually the social distancing, I think it's not a proper, not an appropriate word, because the human or man is a social animal and we need help of each other. And during this pandemic as well, we have, as a human being, we have helped our brothers and sisters during this pandemic. So social distancing should not be there. Physical distancing is the most appropriate word. And WHO came with a guideline that 3 feet distancing should be maintained. CDC said that it should be 6 feet. So what is true? But sneeze can travel up to 8 meters. That is up to 24 to 26 meters or 26 feet and 8 meters, suggesting that some social distancing measures are inadequate. So this was published in the Journal of American Medical Association. So social distancing or physical distancing norms of 6 feet was again insufficient because the virus was able to travel more than 20 feet. So again, it was published in University of California, Santa Barbara. So now coming to the few last slides are there. National Academy of Science and USA. So it said that masks are better than distancing. So many guidelines came. So it was as per this National Personal Protective Technology Laboratory. But definitely vaccination, no one can compare with the vaccination, because worse clinical outcomes are much more likely to associated with no vaccination status. And definitely the vaccination which we have used has reduced morbidity and mortality up to significant extent. And if you see this WHO's COVAX initiative, no one is safe unless everyone is safe. So that was the dictum used by WHO to protect the masses from this deadliest virus. Only thing, it was associated with some complication or some side effects were there, and that too in some sort of population, in a little population. That means fever, myalgia, and all these things were the simple thing, but it was associated with venous vaccine induced thrombocytopenia, VT, venous thromboembolism, pulmonary embolism was there, pericarditis, myocarditis was there. There was some incidences of acute myocardial infarction, and there was incidence of this stroke or severe cerebrovascular accident in some or little population. So with this, I thank you all for your patient hearing. Thank you, and thank you the organizing committee of this Elite CME committee for giving me an opportunity to speak for this topic. Thank you very much.
Thank you, sir, for your detailed information about what was used and what has to be done. Request Dr. Chatterjee to kindly felicitate our speaker, to Zahid Abadda. Thank you, Zahid sir. So our next speaker is an MD in internal medicine, Dr. Yogesh Lakha sir. Sir is professor and ICU head at Indian Institute of Medical Science and Research. Before inviting sir for his call, I would like to request everyone to kindly switch on your videos for attendance. I request Ritu ma'am to kindly shift the setting to gallery.
So this is, as you can see, this is the first page. So there are two more pages. Once we are done with this,
Okay.
participants, then we shall proceed with the next pages, sir. Right?
Yes.
Thank you.
Yes. So I'm taking the screenshots. Kindly keep your cameras on.
So with this, sir, shall we move on to the next slide?
Please.
Okay.
Verma sir, please drive safe. Yes, ma'am, done.
Thank you, sir.
Yeah. So,
So we are on to the next page now.
yeah.
So Dr. Bin Mazi, Dr. Mushtaq Mukhtar, everyone please turn on your cameras.
I have taken the photographs, madam, of all the delegates.
Okay, sir.
Yes, yes, yes. Complete attendance is done.
Right, sir. Thank you.
Yeah, yeah. So Dr. Yogesh Lakha sir, he is a professor and ICU head in Department of Medicine in Indian Institute of Medical Science and Research. Sir is currently secretary of Indian Society of Critical Care Medicine and secretary for Indian Society of Parental and Internal Nutrition. Sir is an approved UG and PG teacher for medical students. Sir has also served as assistant professor at Nair Hospital, Mumbai. Sir is currently president of Alliance Club, and he was also president for the same club in 2024-23. He's for consecutive 2 years. He is the chairman of a program that is initiated by IMA Chhatrapati Sambhajinagar, Aao Gaon Chale. So I request sir to kindly share his screen. Uh,
Yeah, thank you. So thank you for kind introduction. Am I able to share the screen? Am I allowed?
yes, sir.
The
Yes,
screen
sir,
is
we can
visible.
see your screen.
Okay, okay,
COVID pandemic short-term and long-term effects, a critical care
okay.
physician's perspective.
Yeah, it's visible.
Yes, sir.
Okay.
Yes, sir. You can proceed. Sir.
Yeah, yeah, yeah. Good morning, everyone. We have seen the deadliest pandemic of this century, and the last speaker also spoke of that the such kind of pandemic happened 100 years of ago, and the human needs to be ready for such pandemics. There are various climate issues or environmental issues or nature damage, and these viruses are ubiquitous in the nature, and we have seen that SARS endemic was there, then MERS was there. Again, those were caused by the coronavirus, and in the December 19, like we started facing this deadliest virus, and that almost like it lasted for the 2 years, and that was the nightmare for the whole human community. And being an internist, being an intensivist, like it was really what we faced in the ICUs, and the pouring of the patients with moderate to severe ARDS, like it was like a very difficult situation for all of us and our whole team to handle that. And we can see that the short COVID, that we can say the 2 years pandemic, and mainly the it was leading to the damage to lungs, and that leading to the respiratory distress. Many of the times acute respiratory, I'll speak on acute syndrome shortly. Then again I have to deal with the uh, long COVID, that is like post acute situation that is happening, and still some of the patients they are suffering from such syndrome. The short COVID definitely lack of resources were there, like ventilatory supports, and many, like we could experience a lot of things from that short COVID, like during those 2 years of things, like use of NIV, use of HFNC, and then definitely mechanical ventilation, different mechanical ventilation strategies, those like we were using, and importance of those already, like we have seen that many of internists may be there in the participants, like many important strategies they are really important while handling the ARDS patients, like low tidal volume. Again, a lot of learnings for ICU physicians, critical care specialists, we could achieve from this pandemic, and we will be definitely that will be helping us to manage such acute respiratory distress syndromes more effectively in the future. Then recruitment maneuvers are there, then use of PP is there, then help of prone positioning is there, and newer modalities like use of ECMO nowadays, that is also coming. Then extracorporeal CO2 removal, that is also there in the acute scenario, and many things are there. Many things are there, like it is a immunological phenomena rather than just viral pneumonitis. It was that excessive immunological activation or cytokine storm that was basically affecting, that was leading to damage to the lungs, that was leading to damage to many other organs in, and even like multi-system inflammatory syndrome, that those kind of cases we faced during those that period, and those need to be treated. Then sequelae of this short COVID or acute ARDS syndromes that lasted say months, those patients who suffered from really bad lung injuries, those like face these problems like say for 2 months or 3 months to
Recording in
treatment. Even
progress.
like complications related to symptoms, we can see that vaccines even led to some neurological events post vaccination, and that is there with any immunological phenomena. Then non-specific effects of hospitalization, like psychological stress was definitely there, we have seen during those 2 years also. And post COVID also, like many thromboembolic phenomena, or increased incidence of diabetes, or increased incidence of cardiovascular system, those were there. Then like for the year also, then short-term outcomes, like this morbidity and mortality was major concern during those 2 years. Hospitalization burdens, many patients require prolonged hospital stays, particularly in the ICUs. Straining the healthcare systems, complications such as thromboembolism, acute kidney injuries, like need of dialysis, and then secondary infections are common in the severe cases. This we need sepsis could be there in the when the prolonged stay in the ICU is there, that need to be tackled. We have to work on multiple fronts while treating the such patients who need the prolonged ventilations. And recovery challenges, even in the mild to moderate cases, recovery is often slow, with patients experiencing prolonged fatigue, cough, and myalgia. This is like a long COVID syndrome, like we dealt with. then I would like to focus like cytokine storm. Like it was not just a, it was not just a, uh, it was not just a viral pneumonitis. Then it was a immunological phenomenon that led to the damage to lungs and many other organ systems. The association between secondary hemophagocytic lymphohistiocytosis like this and COVID-19 is noteworthy as it has been discussed, and researched. HLS is a rare and potentially fatal hyperinflammatory syndrome that shares similarities with the mast cell activation syndrome and cytokine release syndrome, and is characterized by hyperactivation and overproduction of macrophages and lymphocytes in various tissues, including lymphoid organs, along with the excessive release of pro-inflammatory molecules. This can lead to progression to MODS. This paper was published in the Lancet way back in 2014 also. Like we were dealing with the HLS syndromes, and that particularly familiar or primary HLS syndrome that is seen in the kids, and this secondary HLS syndrome that is particularly that activation of the immunological system, excess activation or cytokine release storm that is particularly seen in the post-infectious stage, and COVID-19 pandemic, we have seen that activation enormously. And basically that immunological damage that was such a way that it made such a huge and big pandemic, and that led to suffering for those 2 years. And one study that was performed by the Claudia in the Journal of Clinical Pathology in 2021 to ascertain existence of the secondary HLS. Several patients with the severe COVID-19 showed that 11 out of 16 patients expressed moderate histiocytosis associated with hemophagocytosis in the bone marrow. The classical diagnosis of this HLH that you need to you go for the bone marrow, and that hemophagocytosis is seen. And this was seen in COVID-19 patients where the bone marrow examination was done during this study. And many of these syndrome like cytokine release storm or HLH or mast cell activation syndrome, those do happen in different scenarios, but that can be the part and parcel of the same immunological damage or immunological activation or excess immunological activation that leads to such multi-organ failure, and that need to be looked into by the internist or critical care physicians, and those need to be suspicion of such kind of things. Why? Because early suspicion of these things you may be able to monitor, you may be able to put actual or some biological medicines you could be able to use, and that may help in saving more and more lives in the acute conditions. Like in the ICU, our experience, our own experience, like we have like got mild to moderate cases almost more than 1000, but really those patients who were needing the ICUs, like 200 patients during that pandemic, I do personally manage. This is our own data, and we can see that death occurred among the 16 out of 200 ICU needing patients. That was almost 8%, and 14 out of 16 were more than 50 years. That we have seen many of the comorbid conditions were there in those above 50 years of age patients, and that additionally lead to more serious syndromes in those patients. Then cytokine release storm, like 40 out of the 200 patients, almost this counted to 20%. Those lead to this cytokine release syndrome, and out of those 40, like severe cytokine release syndrome where the LDH, then we did many biomarkers like D-dimer, ferritin, IL-6, those were significantly elevated. That counted almost to 45%, 18 out of 14 patients. And almost whatever mortality was there, what we have mentioned, the 16 patient those died out of the 200 ICU patients. Standard care were given in all the patients, and these 16 out of those 16 patients were from the cytokine release syndrome or some kind of like HLS kind of thing. This was the immunological severe immunological activation in those patients. That 88% death rate was seen in this severe cytokine release syndrome. And the organs affected were like primary organ affected was the lungs. Then few of the patients, like two of the patients, they were suffering from the myocarditis, where the significant hypotension was there, cardiogenic shock was there, that those that was needed to be addressed, and those were treated. Then there was liver injury, then there was kidney injury also in few of the patients. But such a severe activation of the immune system and cytokine release, that is the basic pathology. Because many of the researchers now, this immunology is the area of research where all the focus is there. The medicines are being developed, biologicals are being developed to cut shorten these immunological phenomena, and biologics are many biologicals, they are acting at these levels. Like regarding the biomarkers, we would like to share this data. LDH and D dimer, those were significantly important when we see in our patients. Like highest value, like 2254, that was seen with the LDH, and the normal value we can see that 450. And if it is going up more than 2 times, that was where it was well correlated with the prognosis. This is our own data, and we have seen that these patients developing into more serious conditions. This is a retrospective, but this will definitely help us to treat of further ARDS or further cytokine release storms which occur in the viral illnesses or endemic form of COVID that we do get in our ICUs this time also. Then D dimer, this was again significant, and when LDH and D dimer both were taken into consideration, that very well correlated with the bad prognosis, and that rising titer of the D dimer and LDH, that was significantly correlating with the prognosis of the patients. And that we have seen almost D dimer levels, that was 10, almost 20 times, 20 times the normal value that we have seen in this pandemic at our single center. Then ferritin, it was very much variable, IL-6 and ferritin. Many of the times these biomarkers were performed, but we could not correlate as LDH and D dimer. And few of the research papers are also are similar things like D dimer and LDH. Those significantly they are correlating. Then low platelet, raised liver enzymes, uh, along with LDH and D dimer, that can be suggestive of those organ damage, or that can be part of that cytokine release storm and or HLH. Ferritin, in few of the cases, those are reported in the literature of significant ferritin level, like more than 5,000, more than 10,000. Those were up to that level, those were raised, and that secondary HLH was the entity, and mortality is significant. And then that HLS, these may warrant for some immunological interventions that you have to know. And few of the myths, you can say myths, or still in the public, how effective were the antiviral drugs in the COVID-19 treatment. Research has shown that when you start the earlier antivirals, particularly like Paxlovid, that was ritonavir, and nirmatrelvir or molnupiravir, those have been approved by the FDA. Then IV remdesivir, that has been help. We have seen that effect when we were managing the conditions. But if it was needing like up to 7 days, we have given. But if prolonged stays there, or if you start it late, then they might not be effective. But as a physicians, as a public for public physicians, we have to always tell the public that just let it be with your treating physician, because many of the time misconceptions are there. They will not allow you to use remdesivir antivirals things, or even vaccines were not taken by many of the public or many of the persons, and that might lead to the increased mortality in such pandemics. Vaccines definitely helped a lot, but definitely the as itself the bigger immunological phenomena was there with the COVID-19, that was also seen with the post vaccination in few of the patients. But that is a natural part of that immunological phenomena that may happen, say, in one in 5 lakh, 1 in 10 lakh post vaccination syndromes. But vaccination and these drugs that definitely will that must have saved too many lives in this pandemic. This was shown at that time only. Even use of dexamethasone, steroid. We started using steroids once, like in that short term period. We have seen that it is a immunological phenomenon, and they definitely, to curtail down that immunological phenomena, dexamethasone or steroid, we have used in the small doses, and that help recovery of many patients. Oral, this drug that has been FDA approved, and this combination nirmatrelvir and ritonavir, that is approved, and that has helped in the early phase. Then biologicals, tocilizumab we had used in few of the patient. Then bevacizumab, that is anti-VEGF biological, that we have used in 4 to 5 patients. That was, but these drugs really, if effect of this, we will need a bigger trials for these drugs. Few of the small patient studies from China and Italy that has shown effectiveness regarding the bevacizumab that way. No, 4 to 5 patients in our study also we have started. We have used these drugs, but as it is a multifactorial, it was multifactorial disease at that time. You have to manage your ventilatory strategies. Then you have to manage that thromboembolism phenomenon. Heparin was used, and along with that, and particularly the chart which I discussed, like when really you need to use these biologicals again early, when the cytokine release storm is there, or it is activating, or the markers are increasing, or that active immunological phenomena is being there, then definitely that early phase, again, this will be helpful. In the latter phase, or once the initial precious time is gone, this may not be effective, because then fibrosis is going to start, and those sequelae of the residual damage of that lung, residual damage of other organs, or patient going into the multi-organ failure, then these all measures may not be effective. That internist need to know, and early is the best always. That is the thing. Then long COVID itself is increasingly recognized complication of the COVID. Secondary complications associated with this syndrome are poorly understood. More clinical data is again required to understand this syndrome's long-term sequelae further. Researchers now thought that this is like inflammation at the low level. Hence, long COVID syndrome may be considered chronic immunoinflammatory complications of COVID-19, governed by latent hyperinflammatory state. Even though this particular syndrome does not currently have well-established and specific definition, thus requiring refinement, its description is solely based on its clinical and biological presentation. Many of the presentations are there. We can see that in the long palpitations we have seen, like that is orthostatic tachycardia syndrome with that affects the heart. Then anxiety we have seen, then depression has been seen. These can be post stress traumatic disorder also, like many of the family members died during that pandemic, and many of such experiences, like we were also very much during those, because we are facing the patients, and we could see from the history that like I can say that one family had come, almost 4 deaths were there on that single day from the same family. This was such a trauma to that family, and the other members, like remaining 2 3 members, we were being treating such a kind of trauma. The critical care physicians do face, but we have to be hard, strongly treat at that time. Then breathlessness, chronic fatigue, this is like the myalgia syndromes. And then memory loss, inability to concentrate. Then chronic chest tightness. Like regarding chronic chest tightness, again, why I am focusing on the immunological things. Then platelet and leukocyte aggregation in the pulmonary system, that has led to this platelet activation. And few of the studies they have shown that, and use of antiplatelets in those patients, that might be helpful in the chronic stage also. Many of such papers have come into place, like use of such anti, because we have seen some of the patients, they suffering from the cardiac events like myocardial infarction in the post COVID, post COVID phase, and that could have they did not have any high risk factors previously. And they do suffer, and this was again related to the low chronic inflammatory state that is happening, and platelet activation is there, that leading to the thromboembolism phenomena, that leading to the cardiac events, that leading to stroke events. Even the immunological phenomena has led to the development of the diabetes in some of the patients who had suffered acute COVID. Then again, these memory issues, joint pain was also seen there. Chronic cough was seen like for a few weeks or something that way. Fatigue was the most common presentation in those long COVID syndrome. Then other all presentations were there, and those need to be treated that way. And this inflammation, chronic inflammation, just like the rheumatological condition or autoimmune phenomena or autoimmune disease, even a few of the studies researchers they have postulated, and some of them have, they have chronic latent infection in the brain. As we have seen that this SARS virus, the receptors are that angiotensin converting enzyme receptors, ACE2 receptors are there, that is again ubiquitous in the body, and this latent infection can be there that lodges the chronic inflammation, and that lead to all these kind of things. Those need to be managed in the post COVID phase. Long-term outcomes of post-COVID syndrome. Then we have discussed all these parts, like respiratory sequel. Either this can be like fibrosis in the lungs and suffering of those patients, or platelet aggregation syndrome in the pulmonary vascular system. Then cardiovascular impact, postural orthostatic tachycardia syndrome that was seen. Autoimmune, this could be autoimmune phenomena. Then autonomic nervous system that may be at fault, and that leading to postural hypotension kind of thing in these patients. And already I discussed the things like multi-system inflammatory syndrome that was particularly seen in the children, but even in the adult, one of our few of like two of those critically ill patients, they had suffered from multi-system inflammatory syndrome, and those needed the inotropic supports, then cardiac supports for those patients. Neurological effects like that, that can be part of the post-traumatic stress disorder, or that can be again part of this latent viral infection or immunological phenomena. Fatigue, chronic fatigue syndrome like symptoms are common, impairing quality of life. Then multi-system effects, persistent inflammatory states may contribute to diabetes onset, renal impairment, autoimmune conditions. Even endocrine manifestations were there that were attributed to like viral injury and inflammatory and immunological damage contribute to post acute COVID endocrine manifestation. Isolated case reports of new onset diabetes and subacute Hashimoto thyroiditis have been reported weeks after resolving acute COVID-19 symptom. Immobilization, steroid use, vitamin D deficiency during acute and post-acute recovery from COVID-19 might also contribute to bone demineralization. Children, we discussed this part. This is one of the entity. Again, for the internist, those who are attending this webinar, I can say that many of these, again, I'll point out to that secondary HLH or less severe form like cytokine release syndrome. Either it can be in the moderate form or a severe form. Then this again multi-system inflammatory syndrome, that is part and parcel of that immune system that is getting activated, and that is uninhibited response and on that immune system. And this phenomena is seen particularly in the children. A new clinical entity characterized by fever, multi-organ dysfunction was there. Then increased inflammatory markers already we discussed. Apart from those, routine tests were available in the clinically. Many markers, many cytokines like TNF alpha and many other markers they do play in the pathology and mechanism in those individuals. In pediatric population, rare but severe conditions like multisystem inflammatory syndrome in children can have, even this has been found to have the long term implications on the growth and organ health in the children population. Mechanism, we have seen that body plays that launch of the systemic inflammatory response syndrome. Again, SIRS, it is the same immunological phenomena, and it is followed by a prolonged compensatory or counterbalancing anti-inflammatory cascade called compensatory anti-inflammatory response syndrome. Many of that is a misbalance between this anti-inflammatory response by the body and this launched inflammatory response again by the body. That counterbalance is hampered, and that this the delicate balance body has to maintain, and this immunological system is at fault, and that can lead to such syndromes, and that can lead to such cytokine storm. This is why, like, this is a multifactorial, and the therapeutic approach has to be multifactorial when you need a real good outcome for your patients, either in the acute phase or you have to be in the long COVID syndrome also. Treatment part, treatment part like endothelial dysfunction, again it is part and parcel of that immunological phenomena. You have to treat with the anticoagulant therapy, anti-platelet therapy. Even in the long COVID syndrome, you may need, and papers are being published those way in now. Then respiratory manifestation, like if chronic fatigue syndrome is there, chronic dyspnea is there, then definitely exercise, yoga, that will help. Then again antiplatelet, that may be helping when there is a platelet and leukocyte aggregation syndromes are being there. Then even digestive system problems were seen, like those can be like probiotics you can use in the long COVID syndrome. Then neurological manifestations, many of the drugs they are being tried, like aripiprazole or naltrexone, those are, or antidepressants, those have been used. Then cardiovascular systems, like you have to manage, just like beta blockers were used for tachycardia syndromes. Then other antiviral therapies, nutrients, these are important. Then liver damage, then that chronic kidney CKD you have to manage, hepatitis you have to manage. Role of antiplatelets, we discussed partially that low grade inflammation in long COVID syndrome sustains persistent platelet activation that is associated with the lung impairment. This was the paper that was published in Journal of American College of Cardiologists, and that has shown that this platelet and leukocyte aggregation that has led to manifestations of respiratory symptoms as well as the cardiac symptoms, and this antiplatelet therapy is going, or that will help such patients. Physician's role, early recognition. Early recognition is always important. Timely identifications of the acute condition as well as complications to minimize the acute and long-term damage to that patients. That is definitely help. Then comprehensive follow-up for the long COVID syndromes, regular assessments for respiratory, cardiovascular, neurological sequelae of the recovered patients. That is very much important. Then rehabilitations, counseling, giving the moral support to the family. That psychiatrist role would be there, and coordinated care involving physiotherapy, psychological support. Then chronic disease management is vital for improving outcomes. Research and educations, this is the important in the COVID-19 pandemic, that has led to, like formulating the multiple and ventilatory strategies. Then use of biologicals, different drugs are being used, so that we have to be prepared if at all, like we need to face any pandemic or any such deadly pandemic in the future. And that's why research is always important. Always suspicion or making that data for the researchers or the colleagues, that is very important. And always you have to go for that. Physician must stay updated on evolving evidence. Then educate patients about the potential long term impacts to promote early intervention. because in India we have also seen that many of the patients, they were not ready to take vaccine, they were not ready to take remdesivir, but that need to be taught to them, and they are not understanding that if some of the patients, they recovered with the same illness early, and but they did not know that some of them, they may be young, and so their body immune response was favorable, and they were just spreading, and just now, like in WhatsApp University, like I need not you need not admissions, and many of the in the pandemic we have seen that because of that many of the patients presented late, and it was difficult to save those lives. Had they presented earlier, like we could have saved more lives with the early intervention. That's why these knowledge need to be spread, scientific knowledge need to be spread, and multi-specialty, like preventive medicine people, and the treating clinicians, they have to work hands in hands with that. uh, Thank you all for this opportunity. Thank you, Dr. Shafi sir, and the whole organizing team. I will just tell, like Indian Society of Critical Care Medicine, that is arranging Sepsicon on 22nd December. That will be held at Hotel Ajanta Ambassador. Please, those who are interested and keen in the sepsis, that is all aspects of the sepsis will be discussed there, and we have the renowned faculties that will focus, that will cover all the topics. There will be interactive discussions for all the clinicians. Please do register for the Sepsicon. Thank you very much.
Thank you, sir, for your in-depth talk about what has happened as a physician's point of view during COVID, and the future perspective of how we can control and how we can prevent further pandemic. Thank you very much, sir. You can stop sharing your screen. Sir, we have this memento of yours
Okay.
with us. So
Thank you.
thank you very much, sir. I'll definitely send it to you.
Yes.
Our so we proceed with our next talk. Our next speaker, Dr. Muhammad Sohail. Sohail sir is MBBS from MGM Medical College, Aurangabad. He has done his MD from Grant Medical College in JJ Hospital. Sir, as a diabetologist, done his diabetes from the Sethi Hospital. He is currently a renowned diabetologist, Chhatrapati Sambhajinagar, working at a Shifa clinic since more than 10 years. Sir is also professor in physiology department of Indian Institute of Medical Science and Research. Sir will be dealing with the topic of long-term metabolic effects of COVID-19. I request Sohail sir to kindly switch on his camera and share the screen.
Thank you, Dr. Zubair. Thanks for this wonderful introduction. Am I audible? Am I visible to you?
Sir, you are audible but not visible right now. You
Okay.
can start sharing your screen maybe.
Okay. My video camera is on.
Yes, sir, you're visible now.
Yes,
Am I visible? Okay.
Yes.
I'll start sharing my screen from my side. So I think when I started sharing my slides, maybe my video won't be available because I'm presenting from my mobile. Is it okay for you? And if the technical person, you can take a snapshot of it if my video is not available when I start sharing my slide.
Yes,
Just
sir,
a
it
minute,
is.
sir. I'm just taking a screenshot of yours.
Okay. Can you proceed ahead now? Okay.
Yes, sir. Please proceed. Thank you.
Thank you. Thanks a lot. You just let me know if my slides are visible to you.
Yes, sir, it's visible.
Yeah. Just let me know if I change the slide, you are able to see the next slide. Is it visible?
Yes, sir.
Yes, sir.
Okay. So it's very difficult to speak after so many renowned and learned people have already spoken in this CME, especially Dr. Laka sir and my friend Dr. Sadek Qureshi sir, and the sole authority on COVID, our Dr. Zahir Abbas Shah sir. So it is very difficult for me, and as these people have already covered so many aspects of COVID-19, even then I will try to do justice to just this presentation. So my topic is long-term metabolic complication of COVID-19. So this topic is very profound actually. It is very difficult to cover it up in 20 minutes or 30 minutes. So these are the important metabolic complications like weight gain and obesity, chronic low-grade inflammation, non-alcoholic fatty liver disease, sarcopenia, endothelial dysfunction, exacerbation of pre-existing metabolic disorder, and dysregulated lipid metabolism due to COVID-19 itself, and COVID-associated coagulopathy and chronic fatigue syndrome. We will discuss some of these complications in detail. So let's begin. COVID-associated coagulopathy, a critical overview. So if you want to understand the pathophysiology of COVID-associated coagulopathy, as the Laka sir and Dr. Zahir Abbas Shah sir has already explained that how the entry of COVID-19 virus is there from the respiratory tract, it is attacking the type 2 pneumocyte, attacking the ACE2 receptors, and type 2 pneumocyte, which were producing all the surfactant, keeping the alveoli intact and preventing the alveolar collapse. This thing is disrupted. And one more thing which our beloved and respected colleagues have mentioned, that ACE is not only responsible for maintaining the RAS system, renin angiotensin aldosterone system, by converting angiotensin 1 to angiotensin 2, but at the same time it is also responsible for maintaining a balance between pro-inflammatory and anti-inflammatory state in the lung. So whenever there is attack of COVID-19, SARS-CoV-2 when invades these cells, especially the type 2 pneumocytes and ACE2 receptor are attacked, the balance between pro-inflammation and anti-inflammation shift towards more of a pro-inflammatory states, as there is a release of pro-inflammatory mediator like cytokine storm, which we have heard a lot of time at the time in the time of COVID-19 pandemic on various webinar platforms. As you all know, my respected friend, that there is a release of interleukin 6, tumor necrosis factor alpha. They contribute to hyperinflammation, platelet activation, and increased fibrinogen level in the blood. And this leads to microvascular thrombosis, the formation of microthrombi in pulmonary circulation and systemic circulation can result in organ dysfunction and in severe cases DIC, means disseminated intravascular coagulation. After going through many research articles, it was very clear that the DIC, which we see in COVID, and especially the COVID-associated coagulopathy, which is a long-term complication of COVID, is different from what we experience in our day-to-day ICU clinical practice, DIC, due to which mostly occurs due to sepsis and other diseases. So what is the difference? Let's see over here. The DIC is having clotting factor consumption, means it's a consumptive coagulopathy. There is thrombocytopenia, and the complication which you will experience in DIC in sepsis scenario is more of a bleeding complication. But in COVID-associated coagulopathy, there are elevated D dimer level, there are normal platelet, and there are thrombotic events, example, pulmonary embolism and stroke. This is the difference. Here you will see bleeding complication, and in CAC you will see more of a thromboembolic complication. The clinical manifestations are evident by pulmonary embolism. A significant risk for critically ill COVID-19 patient is observed in 15 to 25% of the ICU cases. This study was published in Lancet Journal of Medicine, and they also have seen that there were increased incidences of deep vein thrombosis commonly seen in non-ICU setting, affecting 5 to 10% of the hospitalized COVID-19 patient. Other than this, pulmonary embolism and deep vein thrombosis, the arterial thrombosis was also observed with the increased prevalence and associated with the stroke and myocardial infarction due to arterial thrombosis. There were autopsy studies done on the patient who died of COVID-19, and they showed that microthrombi identified in 80% of the lungs in disease patient who died of COVID-19. And this was published in New England Journal of Medicine in 2022. Next important aspect in our body in metabolic health is lipids. You cannot imagine your metabolism unless you imagine and pay attention to the lipid metabolism in our body. Long COVID or post-acute sequelae of SARS-CoV-2, in short, which is referred to as PASC, can have significant and lasting impact on lipid metabolism, leading to dyslipidemia. And before starting an abnormality, we must revise what is the normality or what is the basic, my alma mater, the physiology. Here we will see the dietary lipids, how they enter our body till the sixth step, that is excretion of excess cholesterol through bile, salt, and feces. Let's begin. Don't panic after seeing this complex array and this all drama going on in front of your screen, on your screen of lipid metabolism. But we need to understand this complex metabolism of lipid to have a better understanding of how COVID-19 affects this metabolism. So on your left side, left corner side, you can see the arrow, black arrow is shown over there, and it is showing how the dietary fat which is present in our diet, no matter your person is vegetarian or non-vegetarian, we have dietary fat in our diet in the form of triglyceride, cholesterol, and different component. As soon as they enter inside the enterocyte, they are first they are taken as a free fatty acid, then they reassemble in the form of triglyceride, then they are incorporated into a huge molecule called chylomicrons. Chylomicrons, then they go into the lymphatic circulation through the thoracic duct, and then they are incorporated by ApoB apoprotein, specifically ApoB48, which then throws it into the systemic circulation. And then these triglyceride present inside the chylomicron. On your left side of the screen, you can see that this chylomicron, huge particle is having ApoB48, ApoE, and ApoC2, and they reach adipose tissue. This bottom, on the bottom of left side of your screen, you can see the fat tissue, yellow colored fat tissue is there. Understanding of fat tissue is very crucial because in our world, after the COVID-19, there is a hidden pandemic of obesity going on this our blue planet. You can see there are two important enzymes present over here, the lipoprotein lipase and hormone sensitive lipase, which is not shown over here. The lipoprotein lipase is the gateway which takes up the triglyceride, breaks down into fatty acid, and the fatty acid enter the fat tissue or adipose tissue, and they are responsible for increasing your tummy. Now you imagine your waist size going from 30 to 32 to 34 to 36 and 42. So this is due to lipoprotein lipase activity, which is infusing fatty acid into your adipose tissue. But one more thing is there, hormone sensitive lipase, which makes you lean. But hormone sensitive lipase is inhibited by insulin in a fed state. So after the chylomicrons deliver the fatty acid and triglycerides to the adipose tissue, they are converted into chylomicron remnants. This is very important. I'm coming to what COVID does to these processes. Now, chylomicron is kind of a waste product when it delivers the cholesterol and triglyceride to the adipose tissue. And as we all know that mera kachra meri jawabdari, it goes to liver, where liver has LDL receptor, and LDL receptor takes up the chylomicron remnant, and inside the liver it's a huge factory and a lot of orchestra going on inside the liver. It has HMG-CoA reductase, and we all know that mevalonate pathway leading to formation of cholesterol. All these chylomicron remnant will be delivered to this as a fuel, and these remnant uske andar se then the cholesterol is removed, the triglyceride is removed, and then there is formation of cholesterol. I know there are other precursors of cholesterol also, and there is de novo synthesis of lipids over here, and ultimately there is cholesterol synthesis, which is incorporated into various lipoproteins, especially VLDL. You can see over here in the middle of your screen, the VLDL has come into the picture. VLDL has a very unique protein called ApoB100, ApoE and ApoC2. And VLDL also goes to the adipose tissue and muscle and delivers the cholesterol and triglyceride to meet the needs of the peripheral tissue. And ultimately, when it loses triglyceride and cholesterol, it becomes an intermediate compound called ideal. Ideal and ultimately ideal over a period of time becomes LDL, the most notorious cholesterol of all, and which is known to cause atherogenic complication inside the heart, inside the brain, and inside other organs throughout the cardiovascular tree of our body, the LDL. Now, LDL and LDL provides, but LDL is not that notorious. It is the cholesterol or lipoprotein. Sorry, not cholesterol. It is a lipoprotein which is delivering the cholesterol to one of the major organ like ovaries, adrenals, and the testes. And cholesterol, which we have made him a very bad villain. Actually, he is a hero, and he is producing a lot of hormone which are necessary for our health. All the your steroid hormones are produced from the cholesterol, and remaining cholesterol is collected by our very own beloved scavenger HDL cholesterol, and HDL then goes to then it takes up the excess of cholesterol, goes to the liver, and no doubt there is interplay between LDL and HDL by transferring triglyceride and cholesterol. But what happens to this when there is entry of COVID-19? Entry of COVID-19 and pathophysiology of diabetes has many resemblance, because COVID-19, what it does, one of the major component of aspect of pathophysiology of COVID-19 on the metabolic health is insulin resistance, and which in my clinical practice is the mother of many problems. Insulin resistance is mother of many problems. It is the pathophysiology behind polycystic ovarian disease. It is the pathology behind the type 2 diabetes. It is the pathology behind other metabolic and endocrine complication. It is the pathophysiology behind the acanthosis nigricans, which is occurring in diabetes, though it is the topic of my respected colleague, Dr. Ehsan sir, who is going to speak after me. So what is happening? The COVID-19 is coming and it is increasing the insulin resistance. Once the insulin resistance is there, what it does, coming back to our previous slide, on the bottom of your left screen, you can see the fat tissue is here. What it will do, COVID-19 will cause insulin resistance and it will lead to showering of free fatty acid into circulation. फ्री फैटी एसिड की बारिश हो जाएगी, पूरे सर्कुलेशन में फ्री फैटी एसिड घूमने लगेंगे. And these, mind you, my respected colleagues, these free fatty acids are very toxic, and lot of complications they occur in any metabolic disorder is due to presence of free fatty acid. And the Almighty has provided us a defense mechanism that these free fatty acids are stored as a triglyceride form inside our adipose tissue, the storehouse of our energy. What happens? The insulin resistance lead to stoppage of hormone sensitive lipase, HSL. HSL is stopped. So HSL, once the HSL is stopped, what it does, it will shower the free fatty acid, it will go to the liver, there will be increased formation of triglyceride, increased VLDL, then triglyceride rich VLDL come into circulation, then it will be ultimately converted into LDL, and LDL will lead to its fate, formation of oxidized LDL, glycated LDL, and it will lead to many problems. It will lead to buildup of chylomicron, decreased chylomicron, hydrolysis, and many more complications. Dyslipidemia in long COVID, it's a new frontier, and we have already seen that long COVID refers to when COVID symptoms last more than 4 weeks. And prevalence, if you see the prevalence of dyslipidemia, as there are a lot of preventive medicine people over here, that significant percentage of long COVID patient experience elevated triglyceride and reduced HDL cholesterol. So if in one line you want to speak that what are the complications of COVID-19 on lipid metabolism, that is increased triglyceride, decreased HDL, and variable effect on LDL. Increased formation of glycated LDL, increased formation of oxidized LDL, or in short, increased formation of atherogenic LDL. Clinical significance. The dyslipidemia long COVID elevates the cardiovascular and metabolic risk, requiring careful management. Obviously, it will increase your ASCVD risk score. Unveiling the evidence lipid alteration in COVID-19. I have already told you there is hypertriglyceridemia, there is HDL dysfunction, and variable LDL trends. And what is happening over here? Due to systemic inflammation, due to release of interleukin 6 and TNF alpha disrupts the metabolic and metabolism of lipid, leading to HDL dysfunction and endothelium, which is a smooth lining inside our blood vessel, negatively charged. There is endothelial dysfunction. There is failure to provide an adequate barrier, and then there is entry of these lipid low density lipoprotein, especially small dense lipoprotein, into the tunica media intima, leading to unstable plaque formation. And one more important thing, the fourth number is mitochondrial dysfunction. It is talk of the town in diabetes management. A few years back, there was one new drug launched called imiglivin, which acts primarily on metabolic dysfunction pathway, because metabolic dysfunction is the thing which is leading to decreased energy in the subject. And a lot of patient I come across in my clinical practice, and I communicate with my colleagues which are practicing in European countries. They are saying that they are running chronic fatigue syndrome clinics in their hospital, because it is very much prevalent after COVID-19. Because, and what I consider, it is my own hypothesis, that chronic fatigue syndrome, one of the fundamental basis of the chronic fatigue syndrome is mitochondrial dysfunction. As soon as there is mitochondrial dysfunction, it leads to buildup of reactive oxygen species, and reactive oxygen species causes oxidative damage inside the mitochondria, and ultimately it leads to inside the beta cell of pancreas defective insulin secretion, and in the peripheral tissue it can lead to defective insulin action. Though it is not my topic, it's the topic of my respected colleague Dr. Ehsan sir. So moving ahead, harnessing the management strategies in a multifaceted approach that Dr. Lakas sir has already explained. So I won't be paying much attention on this, that you must do lifestyle modification, and there are pharmacotherapies available to manage the dyslipidemia, especially in long COVID. And especially in lifestyle modification, what is happening, there is a quote, a very funny quote, that nowadays people are saying that we can make you believe in anything by just saying a new study has come up and it is showing that these are the results. And one more funny quote is that a new study has found that 80% of the new studies have got poor results, and they are statistically insignificant. Moving ahead, the long COVID and dyslipidemia, a call to action. We must do more research and come up with conclusion with a larger sample size study to have the exact idea about what parameters lead to impaired metabolic action and lipid disorder and dyslipidemia. And early detection is very important, like diabetes and hypertension. Dyslipidemia is no doubt iceberg disease. There are many more patients who are having underlying dyslipidemia and who are yet to be diagnosed. And we must have outreach program for the patient, for having education about lipid disorders and their consequences. A lot of people, especially after COVID, they have a lot of queries in their mind. They have myths, misconception in their mind, and they think that the biggest problem with your health is doing health checkup. They don't believe in health checkup. वो कहते हैं कि कुछ चेक करेंगे तो कुछ ना कुछ abnormal आ ही जाएगा. But like that, we cannot just close our eyes. By just closing your eyes, you cannot change the problem. And actually that problem, the hidden problem, will become a much bigger problem. At times it may become a threat to your life, as we are seeing day in and day out, young people dying of sudden cardiac death or congestive cardiac failure or myocardial infarction. Because as you know, there is the things they occur, they have a domino effect in them, and initially it is a small thing, and over a period of time it becomes larger and larger, ultimately leading to some catastrophic health consequences. moving forward a collaborative effort, because one of the unique characteristic of human being is that which differentiates us from other living being on the surface of earth is that we can coordinate and collaborate in large numbers. In the International Diabetes Federation and Research Society for Diabetes in India is also referring to collaborative effect towards metabolic dysfunction and all the health problem which come across the people due to metabolic dysfunction. Long COVID and metabolic complication is indeed a very great problem, and it needs to be considered very seriously. Obesity and long COVID, as we all know, that the only thing nowadays which is moving ahead in the time of financial crisis is your own tummy. It is, for initially it was 30 inches, now it is 32, then 36 and 42. And especially when we are looking at it due to in the context of COVID-19 and long COVID, the obesity is due to sedentary behavior. First, as Dr. Uh, Zahir Abbas Shah has rightly said, that first we were put inside our home due to lockdown, and we were made sedentary because that was necessary for mitigating the uh, pandemic. So sedentary behavior leads to decrease uh, basal metabolic rate, reduced physical activity after a prolonged recovery also makes it difficult for a person to burn more calories, decrease muscle mass, decrease basal metabolic rate. And if a person is not exercising, we are losing around 2.5 to 5% of our muscle mass after each 5 years. And COVID-19 also leads to appetite dysregulation. As we all know, the sole site of appetite regulation is your hypothalamus, the ventromedial nucleus of the hypothalamus, and the lateral nucleus of the hypothalamus. And one more important, two more crucial thing for understanding appetite and calorie intake is that our brain regulates it by the feedback of two hormones called leptin and ghrelin. Ghrelin is the hormone which is coming from your stomach, and whenever you are hungry, you know, hunger pangs, you hear the sound, gurgling sound from the stomach, and that is due to ghrelin. Actually, the ghrelin is released and you feel hungry. And whenever there is a fed state, there is ample amount of formation of the fatty tissue and adipose tissue. Then this is appraised to the central nervous system and hypothalamus by leptin hormone. So what happens in COVID-19 and in diabetes as well, there is leptin resistance. So due to leptin resistance, there is uncontrolled hunger. Patient keeps on eating and there is no satiety. Especially it is this is aggravated by bad eating habits, like eating when you are watching TV serials or web series and you don't know how much you have consumed. Looking at the evidence-based statistics of obesity, that 35 to 40% individual who had long COVID have had weight gain due to COVID-19. 60% had metabolic dysregulation, and 50% had leptin resistance. This study was published in Lancet. Moving ahead, the chronic inflammation and non-alcoholic fatty liver disease. Elevated inflammatory marker lead to increased level of IL-6, C-reactive protein, TNF alpha. What we have considered that these are the pro-inflammatory marker in acute condition only. No, there are studies to support this evidence that these parameter, chronic inflammatory, pro-inflammatory parameter, they remain high even after months, even after 12 months or a year post-COVID. And insulin resistance, which is the reality which is happening right now inside the bodies of many patients, even in doctor. And COVID-19 is supposed to make it even more worse. And it increases the prevalence of NAFLD significantly post-COVID infection. And we have already discussed this slide, and it will be kind of a revision to you that the rain of free fatty acid की जो बारिश हो रही है circulation में from the adipose tissue, which is not under the control of insulin, because there is insulin resistance. This excess of free fatty acid and triglyceride, they go and get deposited into the liver, leading to steatosis, increased deposition of adipose tissue in the hepatocyte. Initially they are in the reversible state. Over a period of time there is chronic inflammation, non-alcoholic steatohepatitis, and at times they may be converted into area of degeneration and regeneration, leading to fibrosis of the collagen fiber, and ultimately shrinkage of the liver, leading to cirrhosis, and it may even further go into hepatocellular carcinoma. And the pathophysiology, I have already explained you that systemic inflammation that increase IL-6, TNF-alpha, lead to upregulation of SREBP gene, insulin resistance, hepatic steatosis, and fibrosis progression. Sarcopenia and endothelial dysfunction, I have already told you that we are losing muscle mass if we are remaining sedentary, and COVID-19 pandemic made us more sedentary. And as Dr. Lakas has already explained it in a beautiful manner, that it led to brain fog, lack of initiative, and kind of it made ourselves like having ataxia or bradykinesia, and a lot of us have become couch potatoes, and that has also led to sarcopenia and endothelial dysfunction. And we have already seen this pathophysiology, that chronic immobilization, hypercatabolism, and mitochondrial dysfunction. Endothelial dysfunction, exacerbation of pre-existing metabolic disorder. It is not like that कि COVID-19 आने के पहले हम सब दूध के धुले हुए नहीं थे. There were these and if you consider that the pre-diabetic individual, those are 23 crores. So there is a huge number of patients who are having metabolic disorder, and there is a huge number of patients who are having hypertension, which is remaining undiagnosed. And COVID-19 worsens or accelerates the hypertension due to systemic inflammation and vascular stiffness, obviously, which is a result of endothelial dysfunction. And pathophysiology of exacerbation of the already present metabolic disorder is persistent metabolic disorder, pre-existing metabolic disorder in the background of chronic inflammation lead to worsening of glucose and lipid metabolism and heightened ASCVD risk. So these were all the complications which we have discussed, and I have tried to convey to you that metabolic disorder need our serious concern to be looked at, so that this pandemic is inflammation, NFLD, sarcopenia, endothelial dysfunction, CAC, and lipid dysregulation. It's my personal thinking and message to you all is that if you want to safeguard yourself against COVID-19 or any future pandemic, prioritize your metabolic health now. A well-maintained metabolism not only strengthens your immune system, but also equips your body to better handle the stress of illness. Keep your metabolism in check, and you will be better prepared to face any challenge that comes your way. If you don't pay attention to these challenges or these suggestion of changing your lifestyle, then no amount of CMEs or no amount of webinar is going to protect large masses of people going to suffer from metabolic dysfunction. So key determinants of good metabolic health is diet, a better diet, which is predominant in raw, healthy leafy vegetables, and having lean protein of 25% of the platelet, not platelet, your plate should be full of lean protein, and rest 25% should be in the form of complex carbs. And you must do 120 minutes of exercise in a week, or at least you hit the gym twice a week, and you be active, don't be a couch potato. And you complete 7 hours of night sleep, and you have healthy habits and stay away from the bad habits like smoking and eating junk food. And stress management, Dr. Sadek Qureshi has already spoken about it. So these are the determinant. So if you don't go after what you want, if you don't want a metabolic health, you will never have it. If you don't ask, the answer will always be no. If you step forward, you will always be. If you don't step forward, you will always be in the same place of that bad metabolic health. So start your journey towards metabolic health now. Thank you. Thanks a lot. You were a great audience to me, and thanks a lot, Elite CME Academy, for giving me an opportunity to speak at this esteemed platform. Thank you. Over to you, Dr. Zubair Khazi.
Thank you very much, sir. That was indeed a beautiful presentation, and your orator skills are definitely very high. Sir, you can stop sharing your screen. Our next speaker do not need any introduction, but still as a formality, I will invite Dr. Ihsan Sheikh, sir. He is a renowned consultant diabetologist of Chhatrapati Sambhajinagar Diabetes Care Center. From last 15 years, he is serving the society. He is director of Diabetes Care Center and Kushi Women's Hospital at Aurangabad. He has been a regular speaker in national conferences, regional diabetes conferences. He is a university ranker in diploma in diabetes in 2006. He has presented posters in USDA conference 2011 and many other conferences, having a huge experience as a speaker and presenter. He has participated in the cloud study with the lifting that is was planned by Novartis. He was one of the principal investigation in landmark trials conducted by Sanofi, a life member of the SI and RSDI. RSSDI. He is the organizing committee member of RSSDI, was organizing committee member of RSSDI conference held in 2009 and the treasurer of National Discount 2016. Request sir to kindly take over the screen.
Slides are visible, Zubair?
Yes, sir.
Yes. Good afternoon, all esteemed delegates, respected chairs. At the outset, I would like to thank the organizers, especially the Dr. Shafi sir, Dr. Zubair, and Elite CME Academy for arranging such a wonderful CME and upgrading the knowledge of all healthcare professionals. My topic, Dr. Sohail has really taken to
Sorry to
you.
interrupt you, sir.
Yes.
But your slides are not in full screen, sir.
Yes.
Would you please put in the slideshow?
Yes, I'll do that.
Thank you.
Is it okay?
Yes, sir.
Yes, fine, thank you. Dr. Sohail has really taken you to a molecular level, and he has explained very nicely the all pathophysiological changes in the all the metabolic aspects of and effects of COVID-19. Actually, my talk will be restricted to diabetes. Actually, right? Right now we are facing the two pandemics. Recently, we have faced the COVID-19, and we know that we are the second largest capital of diabetic population in India. And being a lifestyle disease, we are having huge burden of diabetic patients in India. All pre-diabetics and type 2 diabetic, they are increasing very fast. Diabetes and pre-diabetes both are near about 25 crore patients are there. As Dr. Sohail has already explained, that the already this disease is undiagnosed to the tune of 50% actually. So the burden is very high. and we have to be very careful to guide our patients so that we cannot face much challenges in the future life. Now, how this COVID, the incidence and prevalence is really increased after the era of COVID, particularly in last 2 to 3 years, actually affecting the already we are highly diabetogenic as a Asian Indians, and this COVID-19 has definitely triggered the incidence of pre-diabetes and diabetes in our country. Already, as a genetic constitution of the Asian individual, we are having diabetes 10 years before as compared to Western population. Number one point. Number two, we are having high insulin resistance at lower BMI. Our conversion rate of pre-diabetes to diabetes is very high, and the visceral fat content is very high. This makes us more diabetogenic, more hypertensive, prone for hypertension, dyslipidemia, and cardiovascular illnesses. And this, with this background of the genetic predisposition and defect in lifestyle, again COVID-19 has triggered this problem very badly, actually. Now, coming to the relation between COVID-19 and diabetes, particularly, we know that all diabetic patients are susceptible to infection. There are two reasons. Number one is the dysregulation of innate and humoral response, and in COVID particularly, it is the cytotoxic storm, actually. So these 2 points are very important. Now we know that this coronavirus, it is the novel coronavirus. It is the severe acute respiratory coronavirus 2, started from Wuhan city, and first case was detected, reported in 31st of December 2019. On 11th March, it was declared as a global pandemic. Right now, the diabetic, which patients are mostly affected in COVID-19? These are the old patients, patients with chronic medical illnesses like diabetes, COPD, asthma, heart diseases, patient with renal transplantation, patients with basically all comorbidities, obese patient, and patients with the malignancy, those who are taking immunosuppression. These patients were affected most. I will restrict to diabetes, actually. As Dr. Sohail has already explained you the similarity between the pathology of diabetes and COVID-19. Both were the insulin resistant states. They are having chronic inflammatory state in the background. Both were induces endothelial dysfunction. They causes damages to the nerves, leading to multiple problems at different levels of the neurological system, leading to stroke as well. They do affect the lung in the form of pulmonary inflammation, ARDS, and COVID basically primarily a lung pathology. In the heart, they leads to heart failure, myocarditis, atrial fibrillation, multiple rhythmic problems. In the kidney, they do leads to the acute kidney injury, proteinuria, hematuria, and in the circulation, being a pro-thrombotic state, they leads to increase in the cytokine storm and increased coagulation cascade, actually. So both, they affect very badly, and if you can imagine the impact of these two coming together, how they will affect the multi-system affection in the patient, actually. So the diabetes in the time of COVID-19 pandemic, as I already spoke about, uncontrolled diabetes, poor innate immunity, in the background of poor pro-inflammatory cytokines, dysregulation of ACE2 levels, leads to COVID. Again, this COVID causes a direct impact on the beta cell damage. It releases cytokines, ferritin A, leading to insulin resistance, very well explained by Dr. Sohail. And the therapies used for COVID-19, like methylprednisolone, remdesivir, all they again causes metabolic insult and increases the diabetes mellitus. So this cycle goes on, actually, and the severity of disease aggravated by the high blood sugar level. So this is the cycle. Diabetes affects COVID, and COVID affects again diabetic control, actually. So the response is due to a decrease in the immune response, and making it more vulnerable, severe infection, taking longer recovery period. Virus may thrive in an environment of high blood sugar levels. When the people with diabetes develop viral infection, it is harder to treat them due to fluctuation in the blood sugar level and possibly presence of diabetic complications. So always remember, diabetes is not only the sugar disease of blood sugar level, rather it is a disease of blood vessels. It is always associated with some other comorbidities like obesity, hypertension, dyslipidemia, heart disease, to some extent some kidney problem. So these comorbidities makes it more difficult for the managing up to the target levels. So this is the probable a possible mechanism. This COVID-19 directly can cause damage to beta cells, cytokine storm. They both leads to hyperglycemia, worsening of the metabolic control, and could be the new onset type 2 diabetes. One point I would like to highlight over here: many patients, they develop diabetes. Young patient particularly, not having diabetes previously, they got COVID infection. They show suddenly increase in the blood sugar level when they got admitted. Could be the stress, hyperglycemia, could be the direct impact of COVID-19 virus on the pancreas and beta cells and leading to diabetes. This type of diabetes actually was transient, and we treated this type of patient symptomatically for some duration of time, and 50% of the patient, they recovered from this type 2 this type of diabetes, and they became a normal actually. But 50% patients remained in the same diabetic stage, and they continued. So definitely this COVID-19 has impacted the pathogenesis process of type 2 diabetes. There is no doubt about that. So these pathological mechanisms already explained by our beloved previous speakers. This pro-inflammatory state, possible increase in the ACE2 activity, vascular dysfunction, and prothrombotic state. Right now, if you see the stages of infection, particularly it was the stage early infection, then it comes to the stage 2 pulmonary phase, and then hyperinflammatory phase actually. So patients were treated symptomatically. The most important stage where the patients were having hyperinflammatory phase, in which patient shows elevated inflammatory markers like interleukin 6, D dimers, ferritin, TROP-T, anti-pro-BNP levels, and these patients were treated with the corticosteroids, immunoglobulin, interleukin 6 inhibitors, and interleukin 2 inhibitors, and so on. Now, what are the guidelines has to say? As far as diabetic patients are concerned, there were a few points I would like to highlight over here. Diabetic patients shows more. They took more recovery from COVID. Number one, the hospital stay in the ward as well as in the ICU was high as compared to normal population. Number three, the mortality rates were definitely high in diabetic patient as compared to non-diabetic population. Their hospital stay was high, and they took long time for the recovery after going home as well. So these were the 4 points in case of the diabetic patients actually. So the patient who affected most are the patients who had a bad glycemic control before COVID. Right. So high HbA1c patients at the time of affection are the patient who affected most actually. So this is the point very important. So those patients who have kept their diabetes under control, HbA1c in the target range, they affected very less. The recovery period was good. The hospitalization stay was less. The stay in the ICU stay was less, and mortality was also less. So these point to be remembered. So what are the guidelines to say regarding the importance of glycemic control under the current situation? So according to American Association of Clinical Endocrinology, diabetes and high glucose levels are associated with increased complications, respiratory failure, mortality in the hospitalized patient with COVID-19. ADA says your risk of getting very sick from COVID-19 is likely to be lower if you control diabetes in a proper way. According to International Diabetic Federation, people with pre-existing medical conditions such as diabetes, heart disease, and asthma appear to be more vulnerable to become the severely ill in COVID-19 infections. And the RSSDI says the people with diabetes do not manage their diabetes properly and experiencing fluctuating blood sugar levels are generally at risk of for the number of diabetic related complications. So guidelines have also mentioned that the control pre-COVID era was the main thing to be remembered as far as mortality and risk of diabetes infection is concerned in the diabetic period. So pre-existing diabetes, as I already mentioned, comorbidities of diabetes was significantly associated with disease severity or mortality of COVID-19. Pre-infection glycemic control and the disease severity among the patients with type 2 diabetes and COVID, a retrospective analysis, it shows that the risk of COVID severe 19 was higher with the people with high pre-infection HbA1c. And here you can see very well, higher the HbA1c, higher the infection. When HbA1c was reduced by 1%, risk of developing severe COVID infection reduced by almost 21%. So this is very important. Even 1% HbA1c reduces the risk of severe COVID by 21%. Now, the COVID has impacted in two terms actually, right? The direct infection caused by this SARS COVID virus on the beta cell, that is one point. And second point, the lockdown has created lot of environment, a lot of changes in the body of the diabetic patients or the pre-diabetic patients rather, as already explained by the previous speakers. The lockdown has impacted the life very badly actually. The patient, those who are affected most are the patient, those patients who are not taken care of their diet, those patients who are not taken care of their exercise, those patients who have not taken their medicines, those patients who has not monitored their blood sugar levels and not contacted the healthcare professional. So these are the five type of problems where, and due to this lack of the physical activity and erratic food habits and a lot of snacking, there is increased risk of developing obesity, as already explained by Dr. Sohail, and leading to metabolic illnesses, because the pathology lies in the obesity only, and the obesity is the mother of all diabetes, hypertension, dyslipidemia, and other ischemic heart disease and stroke as well. So during the lockdown period, the postprandial hyperglycemia increased due to high carbohydrate content of the people, and this has impacted to the glycemic control actually. So erratic diet, lack of physical activity, restriction in the food supply, and lack in the follow-up of the to the healthcare professionals has impacted to a great extent as far as the disorder is concerned. So lockdown and the disorder lifestyle like weight gain, uncontrolled hyperglycemia during admission and hospitalization when they contracted COVID-19. Hyperglycemia, as I already spoke, in admission patients are it can be due to the direct infection of COVID-19 in the pre-diabetic or high-risk population, or the already type 2 diabetic patients who are affected with the COVID-19. This is scenario number 2. And scenario number three will be the patient taking good control patients or normal blood sugar level patients affected with COVID, taking the medications like steroids and showing the blood sugar level. There were 3 scenarios, and number 4 will be the pregnant patients, ANC patients with the gestational diabetes. So these 4 type of patients we have faced during the period of COVID: new onset patients affected by the COVID-19. Second will be the uncontrolled type 2, controlled type 2 patient taking treatment with the steroids, and pregnant patients actually. So all these type of the patients, how we have to deal in the how we have dealt in this type of patients, I'm going to cover. Now, as I already mentioned about new onset type 2 diabetes due to COVID-19, it could be due to stress, anxiety, depression. Patient get the precipitated new onset type 2 diabetes because these psychological stress leads to release of counter-regulatory hormones and leads to dysregulation of blood sugar levels and blood pressure as well. Lack of physical activity leading to weight gain, unhealthy diet, lack of exercise have precipitated diabetes. Use of steroid has impacted the new onset diabetes, and this was the now labeled as a COVID induced diabetes, which can be transient and which can be permanent, leading to type 2 diabetes actually. So these were the challenges like absent of or less exercise, changes in the diet, decreased activity of availability of anti-hyperglycemic. Many patients have unable to take the medication during the first phase of the strict lockdown. Believe me, patients were on BD doses or TID doses, were taking treatment of OD doses, and they were not checking blood sugar levels. Many patients had not taken blood sugar anti-diabetic medications for a couple of months. They lagged badly in the diabetic ketoacidosis and renal problems, and they got admitted. They got the again the infection. I have seen n number of patients who has affected because of they are unable to take their medication. Many patients are affected because they are unable to monitor the blood sugar levels. Many patients, though those who are affected though from the outside, they are unable to contact the healthcare professionals, even though we were available through the telemedicine and all the possible methods available, but still the diabetes care was not up to the mark to control the blood sugar levels in that particular period actually, right? So the steroid, but if you see the management wise, the steroid a potential game changer in the fight against the COVID. Although guidelines also mentioned that the drug which was helped the patient to bring to a normal state to some extent was the steroid actually. And after taking steroids, we can see that 20 to 50% of patients with the previous history of diabetes show without a previous history of diabetes shows hyperglycemia on the steroid administration. Another study demonstrated that elderly patient with diabetes on chronic use of high dose of corticosteroid had 94% high risk of being hospitalized due to diabetes complications. So here is the possible mechanism of corticosteroids. We know that everything is explained properly. Whenever patients are on steroid, we have to monitor few parameters, which I would like to highlight. Number one, sugar. Number two, blood pressure. Number three is the bone mineral density. Number four is the cataract actually. So these are the four things which are affected by the chronic steroid therapy. So always monitor this type of patient for sugar, blood pressure, give them good calcium and vitamin D supplementation, and do monitor their vision as well. Second thing which corticosteroids affected was the avascular necrosis of the femoral head actually. So there was a quite a good surge of avian after the COVID era actually affecting the young patients, and definitely the culprit was the methylprednisolone or the long-standing steroid actually. So now the administration of corticosteroid compared with the usual care and placebo was associated with 34% lower 28 days all-cause mortality in critically ill patients. That means the steroid therapy definitely helped the COVID-19 patients, though diabetic patients, the steroid has definitely helped to bring them to a normal state actually. Now coming to the management part of the diabetes during the COVID era. So being a lifestyle disease, diet, exercise has to be there. Exercise has shown a great improvement in the immunity, and exercise should be continued whatever possible ways patient could do. That exercise they have helped them, like cycling, treadmill, stationary jogging, because this exercise will upregulate the glut4 receptors. It helps you to reduce the weight. It helps you to reduce the to act oral hypoglycemic agent properly. It reduces the insulin resistance, and it reduces the weight. If you reduce weight by 5 to 10% in a period of 6 to 12 months, you can definitely reduce the dose of oral hypoglycemic agent and insulin. The benefit which are you are going to get with the exercise are not going to get by any other therapy actually. So exercise is very important tool as far as management is concerned. The second point will be the we have to take the adequate doses of or medications. Those patients who are managed on very well on the oral hypoglycemic agent, I'm coming to that, should continue. Those patients who needs insulin, unable to meet the targets in terms of fasting, post meal, HbA1c, we have to shift them on insulin. Insulin was a protective hormone, I am coming to that, and helps to bring the blood sugar level to normal extent. All the organizations have recommended to use insulin in the basal bolus preparation, right? So here are the guidelines by the ADA. Anti-diabetic therapy should be initiated or intensified for the patient who repeatedly have postprandial hyperglycemia more than 180. Target blood glucose depends on the several patient factors, particularly comorbidities. Like we have to, at any cost, we have to keep the blood sugar level in the range of 140 to 180. Monitoring is very essential. Diet, exercise, regular dose of medications, monitoring, keeping patient in the target range, all these factors have definitely impacted the outcomes in diabetic patient, particularly affected with the COVID actually. So owing to the established efficacy and safety profile of insulin therapy, definitely the patient who are not under control on oral hypoglycemic agents, definitely insulin can be used for transient period of time. This was not a permanent insulin for those patients. Those are on affected with the COVID-19, those affected with the ketosis, those affected with the hyperosmolar state. Those patients are in ICU, particularly those patients on steroid. All these type of patients were on basal bolus insulin regime. 3 shots of premix, 3 shots of regular insulin, 1 shot of basal insulin. They have controlled this spectrum of diabetic patients in a proper manner actually. So coming to the medications, metformin, usually we have stopped metformin in any patient in the those patients who are having a respiratory failure, heart failure, or liver failure, or the patients who are in acute illness, particularly, we stop metformin because it leads to some hypoxic state and lactic acidosis. So we stop them. SGLT2 inhibitor again leads to dehydration. So we stop SGLT2 inhibitor. GLP-1 receptor agonist, this is again a good drug. We stop them because it leads to a lot of nausea and metabolic the GI upset. So we stop it. The medicine which we continue was the DPP-4 inhibitors because it has got some role to inhibition of the DP4 enzyme and control the blood sugar level. Sulfonylurea we have to stop when the patients are in ICU setup, particularly. And insulin was the drug of choice. Insulin is the drug of choice in any infection. Patient in ICU, patient on steroid, patient in sepsis, patient with a bad infection actually, because it is easy to titrate. Number one, we can monitor blood sugar level, we can monitor all pre-meals, post-meals, and increase the dose in 1 to 2 to 3 to 4 units in that manner. That gives a good and steady control with proper monitoring, with the self monitoring either or by the continuous glucose monitoring system. IC inhibitors and ARBs, they are having some protective effect in COVID, but the pathology is not very clear. But the use has to be continued actually. Aspirin and statins, we can definitely continue their use because the COVID was the pre-thrombotic stage. So after COVID also, many organizations, they have recommended to use the ecosprin or aspirin to some period of time, but I don't think so. There are some strong consensus to use it in the long run actually. So metformin, SGLT2 inhibitor, GLP-1 receptor agonist has to be stopped. You can sulfonylurea has to be stopped. The medicine we can use was the DP4 inhibitor and insulin actually. Now, how this insulin can be a protective agent in COVID-19 infection? This was the one of the hypotheses, like insulin stimulates sodium hydrogen exchanger, increases pH in the cell, and that reduces the possibility of SARS-CoV-2 adherence to the angiotensin convertase enzyme 2 and causing the cell infection. So by increasing the cell pH, insulin can definitely potentially leads to reduce entry of COVID-19 into the cell. So this was one of the hypotheses, and that is the reason why insulin is recommended by all the organization ADA, AACE, IDF, and RSSDI to use this insulin in a basal bolus preparation. So the treatment with the insulin has to be individualized according to the patient's need, according to his blood sugar level, according to his HbA1c, according to his steroid use, according to his level of sepsis and infection actually. But the regime recommended was the basal bolus actually in all the patients. What we need to monitor is the premiums. Monitoring is very important. All the patients should be educated on typical hyperglycemic symptoms that should prompt them to check their capillary blood glucose levels. Once the dose of corticosteroids are being tapered down, the dose of oral hypoglycemic agent and insulin will also come down actually, right? The patients on the agents, can we are suggesting insulin to the patient, always remember actually, number one, we have to counsel them insulin is not last treatment. Many times we start insulin in between whenever required and we stop insulin. Number two, it do not causes any harm to other organs. Number five, it is the good agent to titrate and keep steady blood glucose control. So whenever we are suggesting, take patient into the confidence and explain him the proper insulin technique, how to give insulin. Number two, explain him the importance of self monitoring of blood glucose level. It is not like that we are giving insulin to the patient and immediately in couple of days blood sugar will come down or it come to normal. No, we have to monitor, we have to upregulate the dose, or we have to downregulate the dose. We have to, dose titration has to be there according to the need of the patient actually. So monitoring is very important. Number three, whenever, sometimes when there is a there is a if there is an imbalance between the diet and the dose and the exercise, patient can leads to hypoglycemia. Always explain them how we can detect hypoglycemia by checking the symptoms. On the symptoms, like whenever patients feels the tremulousness, excessive sweating, palpitations, excessive hunger, always, or giddiness, always check blood sugar level. If it is less than 70, give them the 15 grams of glucose orally. Again check blood sugar level after half an hour. Again, if blood sugar is not more than 100, you can again repeat the 15 grams. So always explain the patient how to identify hypoglycemia and how to has to be monitored for blood sugar level. Explain them the technique, explain them the importance of SMBG, self monitoring of blood glucose level, explain them the how to identify hypoglycemia and how to overcome the hypoglycemia. So all this is the part of diabetic education. We need to sit across the table with the patient, give time to the patient, reasonably explain them the proper technique so that we can get the good and desirable effect of good glycemic control. Because if you see the data of, definitely this indicates somewhere down the line that we are not using medications in a proper way in the light of guidelines actually, number one, and could be the less use of the good drug which is having very good potential to reduce HbA1c like insulin. We are underusing this type of medication, so that that is the reason why we are not getting desirable response actually. Coming to the management of the infected patients in ICU, again the patient has to be monitored for blood sugar levels. Patient on ICU has to be on IV insulin. So prepare a drip of 50 units of normal saline with 55 units of the regular acting insulin, 1 unit, 1 ml, 2 ml per hour. Monitor blood sugar level every hourly. Try to keep blood sugar level in the range of 130 to 140, less than 150. Dr. Lakka sir has already explained you the how to take care of the patients in ICU actually. So this is very important. Patient has to be there on the IV insulin in the COVID era. The second point I would like to highlight over here, keeping patient in time in range. This is a very important and recent tool to monitor blood sugar level on timely basis actually. So this was a small sensor we apply on the patient's anterior abdominal wall or on the arm, and this sensor detects interstitial blood glucose level every 5 minutes actually, and this stores the data. So every 5 minutes where we get all the readings from morning 8 a.m. to next day morning 8 a.m., and we get the trend how blood sugar levels are rising in that particular patient. By holding a small portable mobile like device in front of that sensor, it will sync the data and will get the all the graphical presentation of high increase and decrease of the blood sugar level in 24 hours. That sensor will last for 14 days and will get the data whenever patients are in ICU or patients in patients on the steroid, where you can predict that there could be a very high fluctuation in the blood sugar level. These are the right patient to monitor blood sugar level on hourly basis actually, and we can increase or decrease the dose of their insulin by checking their blood sugar levels and keeping them in the time in range. So if you can see this graph carefully, we have to keep the patient's blood sugar level in this range in between 80 to 70 to 180 actually. So we have to keep this patient in this range actually, not above this range, not below this range. So when we are able to keep this patient 80% time in range, we are keeping blood sugar level steadily, and that gives rise to great impact as far as long-term complication is concerned, as far as recovery from COVID is concerned, and other complications of type 2 diabetes. So this is nothing but the ambulatory glucose profile. This is a very important tool, and this is very not very costly, and we are putting this we using this tool in our day-to-day clinical practice, and this tool was very essential and very helpful in the COVID era, particularly in ICU setup actually. So monitor blood sugar levels, keep the blood sugar level in target range, and whenever you see the patients of diabetes, always check the baseline HbA1c, how much it was there and how your treatment has improved HbA1c in the future actually. So this was very important to monitor the blood sugar levels. And coming to the post-COVID rehabilitation of diabetic patient, as I already mentioned, control of blood sugar level at any cost was of prime importance. The dietary advice, diet and exercise plays a 50% role in the management of type 2 diabetes. Rest will be the adequate doses of the medication. So follow proper diet, take good protein intake in your diet, reduce the carbohydrate content of your meal, take good hydration, take good sleep, avoid addictions, do good physical activity, at least 150 minutes in a week, aerobic exercises, or 15 to 2 to 3 sessions of the muscle strengthening exercise, as Dr. Soil already explained regarding the sarcopenia. Reduction in muscle mass is a very bad condition we can face in the future life. So develop your muscle so that blood glucose level will be reduce and muscle will utilize blood sugar level in a proper way. Monitor your blood sugar level at regular interval of time, and take your medications regularly. Do check your HbA1c at least once in a 3 months. Do check your complications at least once in a year, as far as renal parameters are concerned, as far as your dyslipidemia status is concerned, as far as your comprehensive examination of heart and foot and fundus examination is concerned. This is all the part of a good diabetic management and rehabilitation. So the take-home message from my today's talk: the COVID and injudicious use of steroid will put India on a huge burden of diabetes in the future. Steroid-induced diabetes is a common and potentially harmful problem in clinical practice, especially in the COVID-19 pandemic era. Screen every COVID patient for hyperglycemia at the time of admission. Rational use of steroid in COVID patient is the need of an hour. Optimal glycemic control with safe OAD like DP inhibitor and good insulin regime improve the prognosis of COVID patients with steroid-induced diabetes mellitus. Thank you for the patient hearing. So be ready to fight COVID-19. Be smart, be informed, be prepared, and be safe. Thank you very much for the patient hearing.
Thank you very much, sir. It was always and it is always a great experience hearing you. Thank you very much, sir. Sir, we have a memento for you, which we will be sharing.
Thank you. Thank you, Zubair sir.
So,
Thank you, Shafi sir, for the opportunity.
and also, Dr. Sohail sir, I forgot to tell you that we also have a memento for you. So definitely,
Thanks a lot.
yes, sir, we will be sharing it. Moving to our next speaker. Sir, can you stop sharing your screen?
Sure.
I'll just take a chance to introduce our next speaker, Dr. Shruti Borukar. She is MBBS BCS MD, PGD PC, and PGD MAC, PGDHA, and Aziz Profile. Madam is sharing with an over 25 years of experience as a pediatric and child adolescent counselor. Her interest areas are centered on emotional, psychological, and mental well-being of children. Alongside clinical practice, she is actively engaged in various social activities, conducting workshops, seminars, conferences, and lectures that address pressing health and community issues focused on women and child health. With her literature expertise, many articles aimed at raising awareness and educating the public on important healthcare topics are published in various regional, national, and international forums. She has 5 to 6, literature books and 4 medical books on her name. In healthcare administration, he has taken a key leadership role managing the operations of hospitals and medical colleges, ensuring the highest standards of patient care and health education in medical graduates. In the field of medical education since 2018, he has been actively involved in curriculum, student welfare, and research activities. He has played significant role in administrative in different medical colleges in various capacities. Currently, she is associate professor and pediatric consultant at the Ambassadors in Medical College for Women, Pune, along with administrative portfolios. She is leading her career with a focus on improving the health education system, ensuring quality care, and fostering the next generation of medical professionals.
Shall I start?
Yes, madam. Can you see your PPT?
No, no.
Social implementation.
My CV is seen.
Okay.
Yeah. So, till you share, I can talk. So, thank you, Dr. Shafi sir, and IMSR, my own institute, for giving me an opportunity. And it is nice to reconnect again on a different platform. So, good afternoon, everyone. So, we'll start. Social implications of post-COVID complications. So basically, everyone know the coronavirus, we kept it as a optional point in micro or whatever subject. And one fine day, we all sat for dinner and the whole world around us turned into 360 degrees. So that was really, really a new experience for us. So everybody was frightened, in fear, or some or other anxiety or depression or something like which was very not very normal. We adopted for that new normal, but still some complications are lingering and their effect is seen on whole society, including you and me. So the social implications of post-COVID complications are substantial. They not only affect the health of individuals, but also the social fabric, economic stability, and the overall quality of life. So we'll see the first change, that is the first challenge, employment and economic part. So workforce re-entry and productivity. So it was very difficult to re-enter into the workplace for some people and along with same productivity. So impact, first we will see impact on career progression. So many people, many employees with prolonged absenteeism may face difficulty in promotion and skills update. So everybody was burdened. So especially the industries like healthcare, manufacturing, and education, where the productivity losses were very challenging. Because many post-COVID patients experiences symptoms like fatigue, brain fog, chronic pain that make them returning to previous job with same efficacy very difficult. So there was reduced workforce participation along with reduced productivity. So both were hampered and both were in the problem. So what happened in the career progression? There was difficulties to getting promoted or updating skills. So prolonged symptoms also lead some individuals to qualify for disability benefits. So what that means? So they become difficult post-COVID. So it was again loss of some income, financial hardships, and then the social economic inequality was more underlined. We can see sector specific challenges like essential workers, nurses, teachers, they experience compound effects because of labor shortage and forcing the colleagues to take additional workloads, which was very difficult for at some points. So disability and financial strain, so direct costs, everybody knows the hospitalization and other things like medical test and all that, it was a direct cost. Indirect cost was like loss of income, early retirement, switching to part-time jobs or switching to other job, which is totally different from your previous work. So it was very much difficult for some families, especially low-income families, to handle this disproportionate loss of economy plus overall well-being. So employer adjustment was also there. This part is on employee side, but some part was on employer side. So employers also adjusted during this period and they are still adjusting. So example is like most of the times we say the international or MNCs, they are more pro into the adjustment earlier. So like Google, Microsoft, they introduced policies of hybrid work, mental health awareness programs, mental health day, mental health support. So all these were set because of this COVID and it is still continuing. So it may add a financial restraint to the companies. Then policy implications like some government institutes or some government policies will change their structure, organization pattern was changed, and they have to give some incentives to their employees, like accommodation facilities, extra payment for the work. I've seen when my mother-in-law was admitted in one of the hospital in Aurangabad. So that time she was alone in the room and the management, we requested the management to provide some worker with her all around. So the workers which are outsourced, they were asked to do the extra duty. So it was like that. So every management, every whether it is a private or a government organization, they have to make some changes, make some decisions to help their cater. They have to cater the needs of their patients, their employees, their relatives of employees, or anything related to that. So policy implications were changed, and still they are sometimes continuing. Next slide, please. So we'll see healthcare access and system strength. So increased demand on health services, especially we consider rural health, because in rural area there was no specialized care available routinely. Even today also, the specialized care is almost at a negligible level in rural areas where healthcare infrastructure is also inadequate. So healthcare disparities are seen more into rural, and they are still continuing in the post-COVID era also. So integration of care was also not at that level at rural places, because multidisciplinary care like pulmonologists, cardiologists, mental health professionals, it is a crucial need for post-COVID management of complications. But logistically, it is very challenging, especially when we consider the rural India. And most of the population in India stays in the rural regions. So health inequalities or health inequalities, if we see, if we focus, uh, there are some cases or case studies as done. So CDC has done in 2024. They highlighted that African American population were twice affected, or Hispanic population was affected twice. So it is seen in USA, that study is out, but it will the same effect will show in India also, where the rural population has affected more or in a different or diverse way. So there are some barriers for this. Why health inequities is seen? There are some barriers like language barriers, financial barriers, lack of insurance, limited awareness about long COVID, that is post-COVID complications. So these factors are contributing to inequalities. Next slide, please. So social isolation and quality of life. So both things are very important, because man is a social animal, and loss of social engagement was very much seen in post-COVID and in COVID period. So symptoms like fatigue, memory, chronic pain uh, isolates patients from family, friends, going to like shadi mein jana hai, kahin pe jana hai, so they avoid because of some post-COVID complications. This isolation also impacts on mental health. Well, the anxiety and depression is more seen in post-COVID patients. It's seen today also, even after 2-3 years. So digital divide. So virtual platform was not everybody's cup of tea. So we are accustomed to take lectures online or connect webinars or many other things, or using smartphone and all that. But elderly people or those who are not good with technology, they fear about technology, there was a lack of connectiveness in the society, and it is still continuing. So I have seen one of my distant relative. She's very anxious about those days, and she still feels ki some or other day same situation can happen, and how I will survive. She feels so lonely because she is staying in the remote village at the Marathwada region, and the kids are grown up and they are out in the Mumbai or any other city. So it is very difficult for the older people to connect with their family or friends with digitally or with technology. So it's again a problem for some of Indians or some of the elderly Indians, we can say. So impact mostly seen in elderly population. So again, one point is underlining that pre-existing health issues, and because of limited morbidity or mobility, they have this problem more underlined. Because if the pre-existing health issue is like feeling loneliness or some uh, physical movement or physical mobility problem or issues, it is exacerbated in the post-COVID region era. So impact on family and caregivers. So emotionally, everybody was struggling during COVID and post-COVID. It is continuing still in the post-COVID, because losing someone which we love, which we care, and that person is not like आज था और कल नहीं है. This feeling is very saddening and very disheartening. So ये बहुत सारे लोगों के साथ हो गया कि walking गए थे और आए ही नहीं वापस. I remember one case, like my son was giving some online competition at that period because the whole college was going online, and the 4 participants from his college. So all 4 of them have at least one relative admitted into the hospital, especially in the ICU, and 3 of his friends, the rest of 3, they have lost one parent or one caregiver or one family member, close family member in that period. So students also or families also have very much emotional tone, and still that impact has there with everyone. To losing to family member, it's a great loss for everyone. Financial burden, many caregivers cut back to like work hours or quit job, reducing the household income. Suppose a bread earner has gone or has lost some capacity in the COVID period. That effect of economic constraint is still going on. So next slide, please. So mental health crisis. So mental health crisis increase prevalence of anxiety, depression, and post-trauma stress disorders. So this is seen mainly in children and adolescents because they were not aware of such condition, and elderly one or the parents, they are lost in the COVID, or maybe they are in the morbid stage and they are quit from their job or something like that. So financial burden and what is going on, that no clarity about that. So the children and adolescents are facing such problems very much, and the anxiety and depression is still continuing into these kids. The kids who were at that time children or adolescents, they are carrying this trauma into their adulthood. So this childhood trauma will affect in some or other way into their whole adult life. That's the main worry. So even if counseling them, even if giving them opportunities, even if helping them with finance and all that, even with socially more engaging activities for them, it is still difficult for these kids to overcome that trauma. So there are many cases, there the misunderstanding, even stigma about the COVID and COVID losses is still making these kids very difficult to lead the normal life. So mental health symptoms are often overlooked in the long COVID or post-COVID period. So only the health issues, physical health issues are more focused. And that's why the children and adolescents are not addressed properly, or they are not seen properly, how they feel, how they think about that, and what are the long-term effects. It's very difficult for all to judge them, to solve their problems, to come to a point where the diagnosis can be made and the proper help will be given to them. So it's a very difficult still also. So stigma and misunderstanding is still there. So advocacy efforts are going on. We need to increase that advocacy efforts. We need to remove the stigma. We make them aware about the One Health concept and all that. So they will be more better citizen, and they will know how maybe such pandemics can happen in near future or maybe future. So they have to be prepared for that, and they are also responsible part to avoid such pandemics. So only awareness about what happened into the pandemic and post-pandemic, what are the complications. It's always good to give them advocacy about how to avoid, how to prevent such pandemics again. So, workplace dynamics, employees may hesitate to disclose symptoms due to fear of judgment, or maybe job insecurity. This is really problematic and seen everywhere. Even we see in our hospitals or colleges or any organization related with healthcare. So there is a fear, but when the patient is we suspect COVID is there, or maybe we suspect any issue related with COVID is there. So everybody will be in the mm, fearful mode, or we can say they are ready to help. They are giving the help, right treatment to them, but still some fear is there. So every workplace dynamics is really disturbed, especially in healthcare sector after the pandemic. And still it is continuing. Still there is a stigma. Still there is a, if someone comes in the OPD, or someone comes in the bus also, or train also, we feel like that maybe it is a COVID, maybe it is a something other disease, and we need to protect. Why that person is not using mask, or is there need to be a mask for us when we go into the crowd? Still, such questions, such dilemmas are continuing into our mind. So, especially with workplace, it is more considering we are related with healthcare. So, next slide, please. So, educational impact on children and young adults. So, it's like mainly children and young adults who were in the formative years have affected the learning challenges most. So I've seen my colony kids, like they were in second, fourth, where the socialization was much needed. It was a part of personality development, or any social skills which are required for the long term adulthood responsibilities, or even in education. We say the teamwork should be there. Then some learning, motor development should be there for learning. All these skills were very difficult in that 2 years to develop for the kids, and they will carry this lag all on through the adulthood, or all through future years. So young adults also face, because the uh, exams were going online, so there was some cheating. There was no seriousness to exam, there was no seriousness to learning process. And it has impacted a lot, and it will impact a whole generation. So the generation who was into the formative years in that period, that generation will carry these points or these problems throughout their life, and they will lag behind in some or other way if we I don't address these things properly, or these problems properly. So adaptation is much needed, and it's not only healthcare people's job, it's parents' job, it's society's job. So everyone has some or other role to make these kids, or this generation, or younger generation, adaptable for the future. So UNICEF said that 25% decline in school performance is seen in the 2023 data. So long COVID in a low income countries or low income families, it's a really really worse situation. The after effects are so much that we can't just ignore, we can't just discuss in the CMEs, or in webinars and all that. We need to take action which is really good and helping for them. So even if we think like we will make one person from a low economic background employable, we will give some or other employable skill to that person, it will be good. Because we sitting in the cozy atmosphere in our homes, we can't imagine what these people are facing, what this generation is facing. And after all, it's a society's loss, and again it will add up, and the other way of different loss will occur in near future. So social development, the children are missing, were missing the social development, and some social skills they really missed, and some or other way it will affect their adulthood. So role of schools is also there. they took the role properly. They arranged get-togethers. They made the extra classes and all that, and they tried to catch up them. They tried to bring them into streamline and all that. So remedial classes, they give some extra classes. When the kids were lagging behind, not only academically, emotionally, they supported, but it was not seen everywhere. So this problem still exists and it will continue to exist if not addressed properly or taken care properly. So parental involvement is must, but again, it is based on the parental awareness, sensitization, and then again, economic background, the social or educational level of parents and all that. So considering country like India, these problems will be there because of all inequalities or all the types of disparities we see in the society. So this impact on children and young adults will carry on a long-term basis, uh, unless until we make some substantial solutions for these problems. So next slide, please. So public perceptions and policy changes. So these are the like long COVID as a public health priority. We consider like if heart attack comes, and then there we give the programs of lifestyle modifications and all that. So when there is a major disease or major impact, we cover. Like if there is a earthquake, we give you some incentives or some help to them. So such things are happen, but long COVID, we have not given enough weightage on a policy making for this. So policy making is much needed for long COVID, and it should be like public health policies. Like UK has launched some initiatives for research funding and some strategies for insurance changes and all that. So this should be done for each and everything. So priority should be there because it is a like iceberg. Some part is seen and the lower part is not seen. But the COVID has impacted the society, especially rural areas or low economic urban areas, profoundly. So policy examples and policy changes should be taken into care, and the policy will help, the change in the policy will help to tackle the challenges of post-COVID era. Then global disparities are seen again. The low and middle income countries will lag in the policy development or execution of that policy, implementation of that policy, like other things, or when we consider the other situations also. It's not like COVID is not alone a standing out or something like odd man out, but because it is everywhere, the low and middle income countries will lack always there. So it again will see, and it is continuing to see in the post COVID period also. So the changing perceptions of health and work-life balance. So positive shift is seen, like we just said about the companies or MNCs, Google and Microsoft was the first to introduce, but the companies are adopting wellness programs. They are considering employees' mental health is also important for the productivity and performance. So their overall good effect or positive changes are seen, but not everywhere. But still they are seen, and it should be widespread. So every organization should make some changes, positive changes for the positive well-being of their employees, or the overall work culture should be changed. So there are some challenges, like not all industries can do that, not every organization can do that, because of many other things, not only for financial background. Many other things are very much should be taken into consideration for the challenges, and not it is not every organization's job, but we need to support each and every organization. Like if we are working in a small hospital and if we are working into a corporate hospital, the strategies will be different. If we are working into the not as a healthcare worker, many other employees should as a society, as a social responsibility, everybody should help to make these challenges smooth or streamline these challenges. Then the next slide, please. So what are the implications for future public health preparedness? So preparedness for long-term health crisis. One part is infrastructure development. We have seen the hospitals were full, the beds were not available, the many problems were there, even if we tackled with makeshift hospitals. So एक रात में भी हॉस्पिटल्स बन गए थे, हमने देखा था ये बहुत सारी जगह पे. Still infrastructure development is needed considering all these factors, and research initiatives should be encouraged and should be funded properly. And research should be a part and parcel of medical education right from the beginning. And everybody who is in the science with background and in the healthcare, so they should do more and more research for such things, and they should come out with some concrete information or outcome on which the policy changes will be there. So the preparedness for the long-term health crisis of COVID, post-COVID, and other future pandemics is much needed. Then community resilience and support networks. It is again needed because we live in community and we should take moral responsibility to help the community. It is much needed because the community is us and we are the community. So ultimately, community should be benefited, community should be resilient. Then only all the problems, right, from economic problems to health problems, will be tackled properly. So, like body politic long COVID support group was formed where there were peers and healthcare resources which were made available for the COVID patients. So, such support groups should be there. We have like awareness about cancer survivors or maybe like childhood diseases like leukemia or thalassemia and all that. So everybody support them, like diabetic group, they have juvenile diabetes, they have groups for that. But long COVID support group, it's not seen everywhere. There are no such support groups widespread. So we have to consider such things because many people are not aware about long COVID symptoms, or it is because of, or maybe they are in the fear that I may be infective, because that time it was so much stigma. Everybody was avoiding everyone. So some people or some may think that if I say it's my COVID issue, then again I will be there will be some stigma and I will be like seen in a different way. So we need to support, we need to form such support groups, and we need to extend our helping hand to the needy ones. The role of technology is there. Online forums about awareness, then telehealth consultations, especially considering the rural area, and reducing the stigma associated with long COVID. So we can use that, like AV media is a powerful media, and most of us, or all those society, we can say, is nowadays very much aware about digital platforms, and they see reels and all that, social media influencers and all that. They have good impact on the, not good every time, but they have substantial impact on the lives of whole society. So role of technology is can't be ignored, and we can use technology for the benefit of a whole society, and we can make them aware about the social connectedness, the early symptoms of complications of post-COVID complications, or many things we can make them aware on, we can sensitize them. So in last week, I want to say that the social implications of long COVID extend far beyond health, touching almost every aspect of life from employment to education and mental well-being. A coordinated response involving government, healthcare systems, employers, communities is essential. It's not one man army, it's a full army which will deal the post COVID complications and preparedness for the future pandemics, if there are any. Ideally, we should work to almost there shouldn't be any pandemic uh, in the future. So by fostering awareness, equity in all cases like financial equity, awareness equity, educational equity, mm, then we can say like socially making more inclusive. So this equity is much needed. Then resilience should be there. This is a really good term which should be applicable for every aspect of health. So nowadays, like IQ and EQ are much behind. So RQ is more prominent. That the one who has RQ more will live the life fullest, or uh, we can say will face the challenges of life more easily or more positively. So societies can turn the lessons of long COVID into the opportunities for systemic improvement. So the whole systems should be improved. Uh, we have seen and we say that the public health department and the police department, these two departments have worked in the COVID period very much like इसके पहले कभी नहीं इतना काम किया था उतना वो कोविड में काम किया. That was the saying for them, but it was true. But it should the tempo or that service oriented approach should be continued in the post COVID era also. So the social implications of post COVID complications have led a re-evaluation of care system or healthcare sector, and even work culture, then social support structures. These changes should be taken seriously, and we should think over. We should get some innovative ideas. We should do some research initiative. Those who will roam around this main concept of post-COVID complication related with society or social background. So the social implications are far reaching and require a multifaceted approach to address by increasing awareness, providing support services, and advocating some policy changes. So we can help individuals with long COVID to lead the fulfilling lives and contribute to society. Thank you.
Thank you very much, madam. Uh, Indeed, COVID was one of the social stigma, and the topic that you have choose was very difficult, and indeed you have the situation capacity to justify the topic. So, madam, here is a memento for you, and will reach you very soon.
Thank you. Thank you.
Thank you. Thank you very much.
Thank you.
So, we have our last speaker. Dr. Harshal Karam Pandey, sir. He is MBBS and MD in preventive and social medicine. He is professor head of community medicine, presently at PCMC Postgraduate Medical Institute and Dr. Rao Chavan Memorial Hospital, Pimpri, Pune. He has completed for a National Institute of Health USA sponsored advanced training in health research methodology. He is academic member of the 18th Institute of Education and Research, Greece, He is part working group member for Indian Network for Tropical Diseases, AIMS Kochi. He is an external panel member of National AIDS Research Institute at Navy. He is a member of the board of studies and the board of research of reputed universities. He is examiner for MBBS, MD, Masters in Public Health, Masters in Health Administration of reputed universities. He is a resource person and faculty panelist, quiz master for conferences, CME workshop and training. Honors Lecturer on he is the Secretary of the Indian Association of Preventive and Social Medicine, IAPSM, Maharashtra State Branch 2024 to 27. He is Joint Secretary of Indian Public Health Association, Maharashtra State 2021-24. He is Executive Committee member of Indian Association of Occupational Health, Pune Branch. He is on editorial board of many journals that are Scopus and based in PubMed Index. He's included in Marcus WHO in World Directory USA as a distinguished medical researcher. He is academic and research guide award for excellence in research in 2022 and he renowned in the academician award for 2023. Sir has got around 173 articles published in his name in reputed journals. Sir, over to you. You can share your screen and you can start your talk.
Yes, am I audible to you?
Yes, sir.
Is my screen visible now?
Yes, sir. You can start a slide share view so that we can see it on a bigger screen.
Yes.
Yes, sir. Perfect.
Okay. So at the outset, I like to extend my gratitude to the Academy, Dr. Shafi sir, Dr. Zubair, and Indian Institute of Medical Sciences and Research, Badnapur, Jalna, for organizing this very important webinar on COVID pandemic. I think in last few days we were forgetting about the pandemic, what has happened 3-4 years back. Now people tend to forget, and again the similar kind of social behavior is started on the field. So it is very important to discuss COVID-19 pandemic so that whatever lessons we have learned over the period, we should not forget them and we should continue with the approach which prevented COVID-19 pandemic for many of us. It should be continued. My previous esteemed speakers have excellently elaborated on various complications of long COVID and post-COVID period, including all medical, social aspects, mental aspects. So it has become very easy task for me. Being a last speaker, it is a good summary I can make out from this all these presentations, which I had attended since morning. Uh, I would like to have one disclaimer first of all. Whatever lessons I am right now discussing are mainly based on the personal experiences as a doctor, as a public health professional, as an academician. Whatever I have learned during this COVID-19 pandemic, those I am elaborating, as well as whatever research which has happened or whatever discussions we had at different platforms. So I may not be covering all the lessons learned, but the mainly whatever I felt was important, I am presenting here. Yes, we know that COVID-19 pandemic has offered valuable lessons for public health and medical fields. Nobody can deny that. Okay, there are many personal lessons also, but being a medical CME, I would like to restrict myself to the public health lessons learned as well as the lesson learned in the hospitals or in the medical field. So we'll start with whatever public health lessons we have learned from COVID-19 pandemic. I think first and foremost is the preparedness and early response to the pandemic or anything which is new. Actually, COVID-19 has caught us off guard totally. In the previous talk, Borulkar madam has correctly said that the corona was optional in our microbiology examination. But suddenly it has come up like a novel virus, and we all were affected by this virus. So, first is preparedness. We should be prepared for such kind of pandemics in future as well, because we haven't learned anything from the previous pandemics. One of the speaker has very elaborately mentioned about the previous pandemics of plague, cholera, as well as the last pandemic of 1918 of Spanish flu. But I doubt relax when the things go away and suddenly something comes up. It is just a knee-jerk reaction we have. We don't know what to do. We lack preparedness. We lack early response. That is the most important lesson from the pandemic, that we should be prepared for whatever which is coming. We should be vigilant about it. We should be reading all the time that what is happening in various parts of the globe. Does it has a pandemic potential or an epidemic potential to it? How it will affect my region, my country, my state, my district? All these things we, as a public health professional, we should be continuously doing and continuously researching about it, because delayed responses exacerbate the outbreak which we have already experienced during the pandemic. Second most important lesson for the public health is strengthening of public health infrastructure. When the pandemic struck, that time we were running pillar to post for the robust public health system. We tried to build up hospitals, the COVID care centers in a war footing that was required that time. But actually, we were lacking of a very robust healthcare system, including disease surveillance. Disease surveillance, which is a very important activity, which was lacking at many places. People were not knowing about what is happening, what is COVID-19 when it was initially started. And then slowly we could build up the laboratory network as well, the supply chain, and became so. Our first response was like a knee-jerk reaction, that something has come up and we have to do something. That was the attitude. And when such kind of attitude is there, you are not prepared for what is going on. In the first wave, we have seen that it was totally a mess when we were handling the pandemic. We were not knowing. So we were just mimicking whatever the Western world was doing. That was the biggest public mistake we have done. That we were blindly mimicking the Western world in our public health measures. Rather, initially, when pandemic started, it was handled by clinical people, clinicians, and the public health people were missing in the picture. That was really a very sad picture. Slowly, they have given some tasks to public health managers, and we could manage certain things. But from initial phases only, the epidemiologist and public health people should be involved in any kind of epidemic or pandemic. That is a very important lesson we should take from this pandemic. Third is pandemic preparedness funding. We know when we talk about Indian scenario, we are much lacking behind whatever is recommended by World Health Organization for public health funding. And there is no such a funding which is kept aside for the pandemic preparedness. So suddenly something has come up, and then we tried to have some new kind of funds coming up for this kind of pandemic. And it took some time to gain the funds. We have to divert the funds of other sectors to the health sector so that we can manage the pandemic well. So from this pandemic, we must take a lesson that there should be some emergency kitty we should have for public health emergencies so that we can start immediately and effectively. Now, in the last session, Madam has said about the health equity. Now, we can see that definitely there was no health equity as far as the pandemic in India or entire globe is concerned. The richer were getting the facilities, they could afford the facilities, even they were booking the beds. It has happened at many places. But the poorer got all the brunt of the pandemic. Their jobs were gone, their livelihood was gone. They have to travel thousands of kilometers on feet, walking towards their native places because everything was closed down. It was locked down. So during this period, there was a lack of there was total inequality, and health was not an sector where equity was there. At many rural areas, many hard to reach areas, tribal areas, even urban slums lack basic health facilities which were required during the pandemic. So another most important lesson for public health is there should be health equality or health equity. Everyone in primary healthcare, first principle, what we say is equitable distribution. But still, we have to achieve that equitable distribution in the era of comprehensive health coverage. That should be our first priority. That is equitable distribution of the health facilities in the country. Next important lesson, I think, is a global cooperation. We need stronger international collaboration, transparent communication, and shared resources for tackling global health crisis. It was lacking. It was very much lacking during the initial phases of the pandemic. Everybody was thinking of their own countries. Nobody was coming up to help the poorer countries. Even there was no transparent communication because we call it as COVID-19. It was started somewhere around November, December 2019 in China. But we could come up with the very authentic information only during early 2020. So there was lot of time lag between communicating to the other countries by the affected country as well as by World Health Organization. Slowly things have become clear. Then the global collaboration was there, especially for treatment protocols, vaccine development, but it could have been better. And this is the most important lesson we should learn, because now world has become a global village. We are living in a global village. Whatever happening in the remotest part of the Africa or Europe or Middle East or Asia could affect entire world in just a matter of time, because lot of air travel is happening, lot of uh, global trade is happening on a very quick basis. So anything can be transferred, whether it is infective organism or any new virus or any new very the other parts of the country which are unaffected by that. So global cooperation has to be the foremost priority of the all world leaders, so that we can easily and effectively handle the future pandemics, because pandemics will come. It is not the last pandemic we are having. So everyone should, uh, every country head should be aware of this and should not hide any information, should share it with everyone, so that we all should be safe. Next important lessons regarding community engagement. Public trust and community involvement are critical for the success of health interventions, including vaccination campaigns. Now, if we go back and reflect on how we handled COVID-19 pandemic in the first wave, in the second wave, and then the subsequent waves, there are a lot of differences. In the first wave, it was completely handled by the government, by the policymakers. The restrictions were put on the general public without proper information given to them, without proper arrangements made for them. It was a sudden measure. Maybe that was required, or that was done everywhere in the world. But subsequently, in the second wave and in the subsequent waves of pandemic, we learn that community participation is important. Again, going back to the principles of primary health care, the second most important principle is the community participation. Unless we have good community participation, any of the health intervention will be unsuccessful. We should take the community, whatever community we are living in or catering to, should be kept into the consideration, so that the pandemic should be handled very effectively. What has happened? Sudden lockdown, sudden um, shutdown of all the support system, lack of livelihood, led to mass migrations of the migrant workers to their places, which has done a lot of damage to the entire country, and it has happened not only in India but many of the parts of the globe. So the most important lesson is we should take community in a very proper way. Digital public health. Now we can clearly divide the pre-COVID era and the post-COVID era. Pre-COVID era of digital public health. It was very new. It was used only for the elites. It was only in the urban metros or something like that. It was available. But post-COVID, it has become a norm. Maybe for work from home has come as continuing any business. But in public health also, digital tools for contact tracing, telemedicine, data analytics have enhanced our capacity in the last phases of the pandemic. And it should be going on, because technology is not something stagnant. It is a very dynamic process. So never digital solutions has to be included in our day-to-day practices for surveillance, for data analytics, for diagnostics, for treatment. It is a very important lesson we should learn from the pandemic. Now, previous speaker also talked about the One Health approach. What is happening is that the human has become human race or human being has become such a selfish species on this earth that they feel that they only belong to this earth. They are only living on this earth. But it is not true. There are so many other species which are part of this earth, this nature. And because without any harmony, we can't live on this earth. And pandemic has shown us that anything can jump from the animals or plant into the human race. It is a zoonosis, something from the animals, the virus has mutated and gone to the human beings, and then this whole pandemic is a result of that. Now, everyone, including the World Health Organization, has given due importance to the One Health approach, so that we have recognizing the interconnectedness of human, animal, and environmental health in the preventing zoonotic diseases. And we don't know what may come up from any animal to the human being. So that we should always focus on the One Health approach, and more research should be done this approach. And I think we have taken this lesson, and many new approach. Even the ICMR is coming up with One Health approach specialized institute at Nagpur. So in coming days, I think we are in a better position to handle the future pandemic. Now, these were the lessons which were for the public health point of view, and certain lessons for the medical or hospital based point of view. Sorry. Now, healthcare system resilience. Not resilient for the pandemic. Hospitals need surge capacity planning for beds, oxygen supplies, ventilators, staffing during the emergency. It was totally lacking. All the burden came to the existing manpower, existing infrastructure. Somehow we could manage, but then we have to look for the jumbo COVID center like in Pune or Mumbai or at many places. We have to convert certain centers into hospitals, certain centers into COVID care centers. That resilient healthcare system, and without a proper funding or proper amount of GDP given to the system, it is not possible. I think this is very important lesson. Until we have proper health infrastructure, proper manpower, till we are lacking with the specialized manpower, healthcare manpower. Many places there are vacancies, 30-40% vacancies, especially in remote areas, rural areas. So we need to focus on that, so that our health system, right from the sub-center level to the tertiary care hospitals, we can become resilient for such kind of pandemic. Then importance of primary healthcare. We have totally lost primary healthcare in between. We have become a hospital-based healthcare system over the period. We are mimicking, or we are blindly following the Western model, where it is an insurance-based Western model, where we are focusing on the curative care rather than the preventive care. We should be the mix of both preventive, promotive, and curative care. no doubt curative care is very important, but the preventive and promotive care is also should be given similar importance. And when we have a good primary healthcare system, we can become a very good preventive healthcare kind of society. I think we should take this lesson from the pandemic, that we should focus more on our primary healthcare, right from the village level to sub-center level and primary healthcare centers. They should be more equipped to screen the patients. Otherwise, all the burden was referred to the big tertiary care or secondary care hospitals, and they were overburdened, and many problems faced by these institutions. So our primary healthcare system should be very important, and it should be strengthened over the period. Telemedicine and virtual care. Now in pandemic, our previous speaker also said ki many people with comorbidity has suffered a lot due to lockdown. Clinics were there were movement restrictions. Clinics were closed. So their care for diabetes or hypertension or any chronic ailment was thoroughly suffered. So this is a very important lesson, and now people are actually practicing it, like telemedicine and virtual care, so that even if patient is unable to visit physician physically, they can discuss with the physician or their doctor on phone, on various platforms, and they can take care of themselves at home also. So a very good lesson, and over the period it should be strengthened. Personal protective equipment supply chain. Okay, it was in the initial uh, first phase of the pandemic. We have suffered a lot with supply of personal protective equipments. Even there of lack of face mask also, even sanitizers also. So it is very important to stockpile the PPE kits and other essential medical supplies. There we know that there were lack of supply of important medicines, like the drugs like remdesivir or similar kind of drugs, and we have to then uh, form a committee at the hospital level, right from the collectorate level. They have made the committee, and they used to give certain number of vials of these medicines to the COVID hospitals, so that their supply chain should be continued. Otherwise, there was stock piling, and people were not getting the adequate medicines. People were crying in the queues that we are not getting the medicines. So it was a very bad picture that time. But over the period, government has taken up uh, the entire chain into their hand, entire system, and they have done a very good job after in the second that enhance focus on infection prevention control practices to prevent nosocomial infections and protect frontline workers. We know that in the first phase of the pandemic, many healthcare professionals were affected. Many also died. So it is very important to have a very robust hospital infection control and prevention policy in the hospital. Now, over the period, this lesson is very well taken up by all the major hospitals, and the hospital infection control committees are doing excellent job at many places, so that the frontline workers, the so-called the COVID warriors, should not get affected, and they should continue with their services for the mankind. Mental health support for the healthcare workers. Yes, it was in the first phase of the pandemic. It was clearly seen that there was a burnout of the healthcare professional. Day and night, they were treating the patients. Public health professionals were in the field. They were tracing the patients. They were collecting the data day and night. The data was field on the various platforms, and total lack of their mental health well-being was there, and many medical professionals suffered depression, anxiety. Even some of them are still suffering. So it is very important to give a mental health support to the public health professional as well as medical health professionals, because if they are not well, they may not cater good services to the clientele, and over the period it should be taken care of. Again, some of the incidents still going on, violence against doctors down. We should take a very important step, legally also and socially also, so that such kind of behavior by the general public should not be repeated, and doctors and healthcare professionals should be respected well, and their mental as well as be taken care of. Very important lesson for all of us. Flexibility in medical training. As a professor of community medicine, uh, in the initial phases of the pandemic, the medical colleges were also closed down. Students were sent home, but we need to continue their training. So we have adopted the online teaching learning methods. Even the examinations were online, lexical examinations, and we could somehow manage that. But we need to have more training for such kind of online platforms, because sometimes it is very disinteresting for the listener to just listen to the lecture or something like that. We need to make it more student friendly as well, because this is my personal experience that the whatever system we have used for the online teaching training was not adequate, and we need to again, when student join back, we need to again teach them all the topics which were taken online. So it is the most important lesson that we should uh, progress on this, advance some good medical education technologies, so that our training and teaching process should be continued uh, without any gaps. Data driven decision making. Okay, real time data collection, analysis, and evidence based decision making are essential for effective crisis management. No doubt about that. In the first phase, uh, I would clearly say that the decision making was not data driven. Actually, we were just following certain guidelines given by the WHO or other Western countries. But when we analyze data, then we came to know that where we should focus on, and then proper management of the pandemic was done. So now it's data driven, and government is also doing the projects like Ayushman Bharat Digital Mission, Digital Health Mission. So I think in the coming years, uh, data driven decision making will benefit us for properly maintaining our stand against the future pandemics. Role of non-communicable diseases in the pandemics. Now, non-communicable disease, it has become itself is a pandemic. Okay, when we look at the statistics for diabetes, hypertension, some cancers, obesity, uh, we are the world is becoming the non-communicable disease pandemic all over the world. India is already becoming the diabetes capital of the world. So we need to focus on the proper management of non-communicable diseases, the comorbidities, because they play a very important role for the mortality and morbidity during the pandemics. And I think we should also continue with the care of the comorbidity like diabetes, hypertension, or any other comorbidity during pandemic period also, because many suffered, and during first and second phase, and many totally ignored their disease, or could not get proper management or services during the pandemic. So this is where we have to focus at the disease burden of various non-communicable diseases, and accordingly we should make our policies for the future pandemics. Certain cross-cutting lessons also we should discuss, I think. Yes, we lack a clear, consistent, and science-based communication in the first and initial part of the second phase of the pandemic. One of the speaker also mentioned about the WhatsApp University and the lay people information or misinformation, which has led to many crises. So it is very important lesson that the communication to the general public should be very clear, very scientific based, and it should be consistent. There should not be any confusion uh, for any information to the public. Resilience through collaboration. This is very important. Collaboration between public health officials, healthcare professionals, researchers, and policymakers is crucial during health crisis. We should all sit together and make a policy. We should not be like our. There should not be any watertight compartments between the public health, the hospital management, the researchers, and the policymakers. If there are watertight compartments, there is a lot of confusion and a proper policy may not be created. So we should have a very collaborative platform, and this platform should be active all the time. Not like that during only the epidemic or pandemic, this platform should be there. Like today's CME, I must congratulate the organizers that they have involved not only clinicians, ICU specialists, they have also involved the social scientists as well as public health professionals. So this collaboration is very important so that we can learn from each other and make a very resilient policy for future pandemics. Vaccination as a cornerstone. Okay, vaccination campaign must be prioritized with equitable access to minimize disease burden. History has shown us that with vaccination, proper vaccination, we could definitely eradicate and eliminate the important diseases from the earth. So it should be a continuous process. Vaccination preparedness is a very important field, and the research on newer vaccines and then how to provide this vaccine to the last person in the row, that is also important. WHO has taken up the initiative of providing vaccines to the poorer countries. That is really appreciable one. Even India has supplied vaccine to the many countries of the world which were lacking the infrastructure for vaccine preparedness. So it should be one of the cornerstones and very important lesson for the future pandemics, that it should be a continuous process, and we should manage the vaccination campaigns at all the places in the world, because even if there is one case, we all are at the risk. So everyone, every nook and corner of the world should get a proper vaccine. Now applications and what should directions based on the strengthen the public health system. We need to develop comprehensive
Recording in
plans.
progress.
We have to continuously see our plans, revise our plans depending on the scenarios at our regional level, local level, at the global level as well. Improve surveillance and reporting system. One of the good example is now this IDSP, Integrated Disease Surveillance Project, IHIP portal, Health Information Portal, is doing excellent work. All the major hospitals are regularly on the daily basis providing data on this platform, on this portal, and at the national level also they can see where there is some problem is going or some clustering of similar cases, something like that, and they can immediately start they can tell the local health authorities that this is happening in your area and you should take care of this. So this should be further improved, not only for the communicable diseases, for also non-communicable diseases also. This kind of platforms are important. Investigating the One Health approach that is now coming up. Indian government has taken a very important step of starting a institute on World Health approach at Nagpur, and I think in future we will be better prepared. Build resilient and healthcare. Especially in the healthcare sector, our infrastructure should be robust, right from the subcenter to the tertiary care hospitals. Maintaining of essential health services is very important, and promote telemedicine. I think telemedicine is one of the very important keys and a very important application we should consider over the period, because it reduces the burden on the hospitals and the secondary and tertiary healthcare systems. Cost and equity and access. Again, we have already discussed that lack of equity has led to so many problems during pandemic. So we should have the health facilities available everywhere in remote areas, rural areas, as well as in the urban slums also, so that we can address the health disparities in a proper way. Strengthen research and innovation. No doubt, research and development is the cornerstone for our preparedness. And this is, I think, every medical college, every health institution should focus on certain important research areas and do proper research, publish that, discuss that research on various platforms, so that we all know and we are better prepared. Invest in data analytics, that is going on. Ensure adequate resources, that is stocking of critical supplies, personal protective equipments, essential drugs, vaccines, and local manufacturing capacities. With Make in India project, I think many personal protective equipments, essential medicines are now being produced in India, and that is a very good lesson, and the application of this lesson we have taken from the pandemic. Protect healthcare workers. We have already also discussed. We need mental health support for the healthcare workers. Few days before we were COVID warriors. Now nobody recognizes us as a warriors. And again, the violence against the doctor and other things have also started up. So it should not happen, and there should be some legal entity for that. That doctor community and the healthcare professionals should be protected from any kind of violence, whether it is physical or mental violence. And they should have a very regular training for themselves also, for protecting their physical and mental health also. Because as doctors, as a healthcare professional, we tend to ignore our own health as well. Enhancing communication, strengthen risk communication, engage communities. I think it should be a long-term goal that our community engagement should be optimum, so that we can properly handle the pandemics. This is very important. Promote global and national cooperation, and at many platforms at WHO and other international agencies, I think they should take up this particular reason to promote global cooperation and national coordination as well. Integrate digital health tools. Now Ayushman Digital Bharat Mission, we are applying this particular lesson into the practice, and emphasize on continuous learning. Okay, as initially I said that we were forgetting COVID-19 pandemic, and this particular CME is a good uh, example that we should not forget such an important pandemic. We should learn from this pandemic over the period so that we are better prepared for the future pandemics. And such kind of regular training and education programs should be held at various platforms, and also for the general public, because we may not forget, but the general public may forget the pandemic and may come back to the previous habits, which may boost another pandemic. So everywhere, right from the school level to the college level to the medical colleges, at policy making level, this kind of training and education activities should be continued very regular. So I think whatever personal experiences I had in the public health and the medical field, and based on some research, point out some of the important lessons we have learned, their application. I am very grateful to the Indian Institute of Medical Sciences and Research, Jalna, Elite CME Academy, and especially my friend sir for providing this opportunity to present my work in this particular CME. Thank you.
Thank you very much, sir. Also, you can stop sharing your screen, because last Dr. Muhammad Shafi sir, Director of Elite CME Academy, to kindly take over for providing water.
Thank you, Dr. Zubair. Now we have come to the end of our webinar on post-COVID complications. I am very thankful to all speakers. They have very nicely delivered all the talks. Dr. Sadeh Qureshi, Dr. Zaisha, Dr. Yogesh Laga sir, Dr. Ehsan sir, Dr. Trupti Bodkar madam, Dr. Harshal Pandey sir. All these people they have delivered a very excellent talk. I hope that this day has become an academic feast for all of you. So once again, I thank all the delegates for joining us, for believing us, and staying with us till the last session of this CME. Now, we would like to present the memento of appreciation to Dr. Harshal Pandey for his excellent talk. You can see that Dr. Zubair Khazi is holding the memento of appreciation for Dr. Harshal Pandey.
Thank you, sir. Thank
So
you.
all these mementos will reach you. So on behalf of Elite CME Academy and JIIU's IMSR, Badnapur Jalna, I am very thankful to all the speakers. They have done a very excellent job. Also, our colleague in Elite CME Academy, Dr. Zubair Khazi, Dr. Jawal Hashmi, and new partner for this CME, ClearNet.in from West Bengal. They have given us the digital support, Zoom platform support. We are very thankful to them also, and in the future also we are likely to work with them. So this was the 6th CME organized by Elite CME Academy for 2 points, MMC Accredited CME. We regularly organize every 2 to 3 months one CME, one CPD or a webinar is organized. Probably in the month of February, we will have one more webinar on good clinical practices, because it has become mandatory for all the postgraduates to undergo good clinical practices workshop. That course is made mandatory by NMC and MUHS. So that will be again organized. Last time we organized it and we got a very tremendous response from all over India, particularly from Maharashtra, Gujarat, Telangana, West Bengal. These four states, majority of the participants, they took part in good clinical practices. So day by day, we are trying to develop and promote more and more CPD, professional development programs, which are uh, encouraged by Maharashtra Medical Council. So take into consideration that all MBBS graduates, they are supposed to renew their registration with Maharashtra Medical Council, and they need credit points. So we try to conduct 2 points CPD or webinar so that you people not only get the CPD points but also get some academic knowledge. So once again, on behalf of Elite CME Academy, I will like to thank all the delegates for joining us, all the speakers for delivering excellent lectures. Elite CME Academy, JIS MSR founder chairman, dean, CEO, and all other staff. So thank you very much and have a good day. Thank you. Over to Dr. Zubair.
Thank you very much, sir. Your e-certificates will reach you by the email that you have registered with us today or maybe tomorrow. And your MMC points will be upgraded in around 10 days as per the procedure of the MMC. We have taken your attendance 3 to 4 times between the sessions. Don't worry if your video was not open. Your name was displayed at the window that was for your attendance. So I will Ritu Parna Madam, are we okay for ending the session?
Yes. Thank you, everyone. Thank you, dear doctors, for sharing such valuable insights. And I hope you had a seamless experience. So thank you once again for extending us the opportunity to host the session. And we are definitely looking forward to host you again very soon in the future. So till then, stay safe and healthy and have a nice day, everyone. Have a good day. Goodbye.
Thank you, madam, for your support. So,
Yeah, right, sir.
by the permission of our director, I declare this webinar to be end. Thank you very much.
Thank you very much. Thank you. So we are ending off. Goodbye, everyone. Take care.